Good morning, dear all. We are going to start our today's CME shortly. Before that, I would like to request you all, please log in with your original full name and which will be helpful for us to give you MMC credit points. And please kindly note, do not write anything in chat box, not your name or MMC registration point. We will be back soon. Be patient. Thank you.
सबको म्यूट किया है ना?
A very hearty good morning, all my dear friends, colleagues and seniors. I am Dr. Tina Shial and we present before you the webinar on 7th respiratory updates. With all your good wishes and Almighty's blessings, we have been able to conduct our respiratory updates successfully year after year. This year, again, we have a galaxy of star speakers lined up for you. We are sure that all the speakers, with their profound knowledge and decades of experience behind them, will strike a chord in your mind and heart. Given the pandemic situation, our theme for today's is undoubtedly COVID. We hope to give you crystal clear messages about current COVID concepts. Obviously, it goes without saying that great efforts went in preparing for this day because the preparation would not happen overnight. We have tried to make this CME a delightful, engaging, and interesting knowledgeable feast. We are sure that you all will feel enriched with knowledge after completion of this event. We extend a very warm welcome to all the renowned speakers and delegates who took out their valuable time and joined us today to be a part of the conference. We are honored to have you all with us. Before we begin, we would like to thank the Indian Medical Association Thane branch for having helped us with the accreditation and providing our CME with 2 points. We would also thank Indian Medical Association Mulund branch and Thane District Medical Practitioner Association TDMPA for having wholeheartedly supported us in our endeavor. I'd like to mention that if anyone is having questions, please type them in the chat box on your screen. We will take up the questions at the end of the lecture on your behalf. And yes, if anyone is having trouble connecting with the audio, then please log out and log in again. So, hang on to your seats and as we begin with one of the most popular series in our CME, and that is about case snippets in COVID. We would like to call upon Dr. Subramanian Natarajan sir, who is a practicing pulmonologist in Mulund, Mumbai since last 13 years. His talk is always amongst the most awaited ones and garners a lot of appreciation from all of us. Today, he's going to give a practical case discussion on COVID patient management. Please welcome Dr. Subramanian Natarajan sir. Over to you, sir.
Audio. Yes. A very hearty good morning to all of you all. It's been a pleasure, and we are meeting after quite some time because of the pandemic situation. We are here on an online format as a webinar. Otherwise, we would have just enjoyed on the stage and in a hall, talking and laughing our things out. And it's our honor that we have had a large number of registrations, almost 1,150 registrations today. And I hope many of you all are joining quickly. We already have more than 250 participants already who have joined the meeting now. And we hope that this would be an excellent program, as excellent as all the preceding 6 years have been. And before that, there are a couple of things which I wanted to tell you. Just as Dr. Tina was highlighting, we would want to rename yourself so that when we have a final printout of the list of attendees in the Zoom meet, we would have your exact names. No need to send your MMC numbers. We have it on Google Forms. We would be giving points to all those who have come here, and those who have attended the meeting, we would be giving MMC points. Don't worry about that at all. We just want you to rename yourself properly so that we have your full name, accurate full names. And this chat box, please don't use the chat box to write your names or write your MMC numbers. We don't want that. We want the chat box free only for questions. We are tracking questions for all the speakers, and one of us would be asking the speakers on your behalf. And so These are two things, and if at all you are unable to hear us, we have our audio visual unit here. We are able to hear all our audio visual excellently. There's no issue with our audio. Please log in and log out again. We'll be admitting you immediately. And I think without further delay, I would like to start my lecture. Just a second, please. Okay. All right, so I hope you all can see my slides. Now, this is all our own data and own experience. We have not taken anything from the internet. We are going to talk what we have been managing in COVID for last almost more than a year now, and we are going to give you certain cases. Now, besides this, at the end of the cases, there would be a question, like you would be given 4 options. One of those 4 options you have to poll. So there is something called as a polling. So once I tell you to start polling, please poll within 10 seconds, and we would have the poll results immediately at the end of 10 seconds, and we can discuss further on the polling aspects and on the questions as well. So be ready, be glued to your seats. And the first case is a 55-year-old female. She is an RA positive on immunomodulators. She is on mycophenolate mofetil. And so she is on mycophenolate mofetil. She's a case of interstitial lung disease. We have given her steroids in the last almost a year, couple of times. So what had happened is she's also a diabetic, and she had 1-day history of fever. At her home, her daughter was COVID positive. She's a Marathi film actor, and she went to the stage, and she goes to stage shows and this and that. All these people, they roam around at hundreds of places. She got COVID. She transmitted it to her mother, but she had very mild illness. She had just mild throat irritation, mild cough. She tested positive by a rapid antigen method. Her saturation was bank normal. They consulted me on day 5th or day 6th. She was normal. She was hardly symptomatic. So what will you do? A, do RT-PCR testing for confirmation. B, start on ivermectin or doxy. C, give steroids. Because she is high risk, she may deteriorate anytime. She was on immunomodulators, diabetic, old age, a lot of comorbidities. So you want to give steroids so that you don't have any issues later on. You don't want her to worsen and go to the ICU. Or observe and give symptomatic treatment. Can we start the polling, please? Yeah. So the poll will be on your screen. You can start polling. You'll be given 10 seconds. So the polling is on your screen. You'll be given 10 seconds. 8, 5, 4, 3, 2, 1. I think we can end the polling. Or you want to do it once again? Did everyone do the polling? Only very few people voted. I think just 20 voted. Should we relaunch the polling? That's better, I feel. Can we relaunch the polling? Please, we are relaunching the polling. This is something new for all of us. Please poll. There are almost 280 people. Please poll. Is just a thumb of, you just have to press your thumb and choose one of these answers. We want you all to poll in large numbers, otherwise the results would be skewed. So just 90, 100 people have voted till now. Come on, fast. Or is it sleepy? You have not had your breakfast. It looks like people are eating breakfast and not polling. Keep your spoons away. Looks like I think we can stop the polling, end polling, and can we have the results, please? Share results. Okay, are these the results? Okay, now many people have said we need to do RT-PCR for confirmation. Good. You want to start on ivermectin, doxy, then give steroids, observe and symptomatic. Majority people have said observe and symptomatic treatment. Almost more than 1/3 of the people have said that. 1/3 also want to do an RT-PCR. Okay, I will go back to my presentation now. Okay. So basically, antigen has very low sensitivity, but very high specificity. If antigen is positive and if there are typical symptoms, I would not think of doing an RT-PCR. Makes no sense. You don't want to wait 1 or 2 more days for you to get an RT-PCR, then think that this is a COVID positive case. So doing RT-PCR for confirmation makes no sense. If antigen is positive, you just have to label the patient as COVID positive. If antigen is negative, yes, you have to do RT-PCR. Now, we have all been giving lot of medicines to many patients. The first thing which I tell all my patients is COVID has no treatment. So I would not give so many poly drugs, many drugs to all these patients. So ivermectin is not known to be useful. Doxy is not known to be useful. Antibiotics are not known to be useful. So I would not be giving this patient any antibiotics or a lot of medicines. I will show you in the next slide. Third is give steroids. Very, very dangerous. I will not give steroids to my COVID patients in the first week of illness. So giving steroids is like the first week is viremia phase. We all know when there is active viral replication. We do not want to give steroids and make the patient go weak on his immune system, cause more viral replication. We have seen patients dying. Believe me, we have really seen patients dying who have been started on steroids in the first week. So giving steroids is strictly in the second phase, in the immune phase, that too only when there is desaturation. Only when saturation goes below 93, 92, that too not just one reading, we'll wait for one reading, 2 reading, 4 hourly, 6 hourly. After 6 hours, 8 hours, if still the saturation is low, patient is starting to have increased symptoms, that is the time when you will admit the patient and give steroids. Do not give steroids at home. So my probable answer for this patient is just observe. She's mildly symptomatic or almost asymptomatic. You just have to observe, ask her to check her saturation every 4 hourly. Tell the patients that 7th to 10th day is when you're going to have complications. That is the time when I want you to do your saturation checking and temperature checking every 4 hourly. If there is desaturation, then you contact me back and we will get you admitted in the hospital. So for us, it is just an observation, observe this patient. Unfortunately, this patient was given, this was just 7th of May. This was not very old. This patient was given a lot of things like ivermectin, not required, doxy, not required. Limcy, okay, it's a good chewable tablet, gives good taste in the mouth. Many of our patients have loss of taste, you can give it. Zincovid is fine. Decmax, very dangerous, I will not give. Monterefx, useless. Pantene is fine. Now, a word about Fabiflu. Favipiravir was touted as next antiviral for COVID, anti-COVID drug. However, it just became a costly elder brother of HCQ, and it did nothing else. We also gave it's not that we have not given. We have given Favipiravir to a lot of patients in September, October when we had our first big wave, but it really didn't matter. It didn't really prevent the patient from ending up in hospital. There were some pharma control trials which said that favipiravir causes early viral clearance, but then that 2-day viral clearance didn't really make any clinical difference. So this wave in April, May, I didn't give favipiravir to anyone. It has high tablet load, lot of GI side effects. So I wouldn't really want to give favipiravir. Cherry cough, yes, give a good cough suppressant, codeine, dextromethorphan, levodopa-propazine, levocloparastine, whatever cough suppressant you give a good cough suppressant, unless the patient is an asthmatic and he has a lot of wheezing and breathlessness, then you can give a cough expectoration. Otherwise, give a cough suppression, patient will sleep well, they'll feel better also. This was another prescription which was sent to me by one of my doctor friends. It was given to her asymptomatic father who incidentally turned positive because his wife turned positive. He was asymptomatic, he was not having any issues. See the amount of medicines. We will pledge that we will not give polypharmacy. We do not want to over medicate our patients. Mucinex, Predmet, all these Apigut 2.5. I'm going to talk at length regarding the blood thinner. So this prescription is not going to help. A word regarding investigations, I would just do CBC, CRP, D-dimer in high risk patients with comorbidities. Otherwise, I would not touch ferritin. I would not give LDH. I would not do a CT scan in an asymptomatic patient. I would not do CT scan in an RT-PCR positive patient stable. I would not do. I will not do CT scan for deciding admission for a patient. In case if we have high clinical suspicion and RT-PCR comes negative, then it makes sense to do a CT scan. Otherwise, let us not order repeated CT scans and then decide for admission or anything. The CT score is not going to tell us that CT score of 13 or 15 is you need to admit or something. Okay. Anyway, there are speakers who will speak on this. So my case too was now a lot of patients get admitted now. Not many have an opportunity to admit COVID patients. Many of us are physicians. We are family practitioners. Not many of us have opportunity to admit COVID patients under your own care, and maybe many of the hospitals where we visit don't want to make it a COVID center as well. So even in last wave, I didn't have the opportunity to admit many of my patients, but this way we managed a lot of patients because one of the hospitals where I used to go, they made the BMC push them to make it COVID and there to make the entire hospital COVID. So I didn't manage COVID patients. So this was one of my patients who was admitted for 17 days. They managed him beautifully. They gave him remdesivir, steroids, low molecular heparin. He was quite breathless when he admitted, but subsequently he improved dramatically. He had good response to medicines. He was discharged with just one or 2 liters. Only while walking or going to the toilet, he used to feel mildly breathless. He used to use oxygen. Relative also said there is significant improvement. He was not given BiPAP or NIV. So this was the discharge summary. If you can see clearly, 17 days he was given steroids. Then subsequently he has been given, I hope you all can see the discharge summary clearly. He was given prednisolone 10, TDS for 5 days, BD for 5 days, OD for 5 days. That means 32 days he has received, he is going to receive steroids. Zifi is fine. Vitamin C, D is fine. Zincovid is fine. Ecosprin Gold and Xarelto, one anticoagulant and one antiplatelet agent. We are giving him double the dose of blood thinners. Pan-D is fine. And see the last one, Perfinex, 200, 2 BD. That means 4 tablets of Perfinex until next follow-up. So a patient who has dramatically improved, is having very less symptoms. Do we really need to give Perfinex? There's a question. Anyway, the question for you all is, now the polling will start. Please poll in large numbers. We'll have a good data now. First is continue steroids for 1 month, continue Ecosprin and Xarelto for 1 month, continue Pirfenidone 4 tablets a day for 2 weeks, pulmonary rehabilitation, breathing exercise. Which of these? So this patient is going to come back to you and ask you, Doctor Saab, ye diya hai. Now you are my family doctor, you are my treating physician. I don't want to go back to that hospital. Anyway, I have lost a lot of money. I don't want to go back. It's a COVID hospital. Relatives don't want to get exposed. You tell me, you treat me. Now what are you going to do? Tell me. Now let us have the polling, please. Please poll in large numbers. The polling starts now. Start, please. We have almost more than 300 people attending. Fast. Poll fast. Excellent. Very good. It should reach 300 within no time. It's just reached 100 if I can see. Can you all see the options very well? Yes, very good. Please poll fast. Can we have another 5 more seconds? So 5, 4, 3, 2, 1. Let's stop the polling. Stop. Can we have the results, please? Excellent. Wonderful. This is what I want. Almost more than 80% have have given their option as pulmonary rehabilitation and breathing exercises. Excellent. Some people have given Ecosprin and Xarelto. Some want to give steroids. Some Pirfenidone. Very good. Very good. Excellent. So I think I will go back to my presentation again. So basically all guidelines all over the world tell us that, even recovery trial told us that you give steroids only for 10 days. The moment he started to improve, taper off steroids. Even in our ICU patients whom we are managing, patients are there with us for 1.5 months. After 10 to 12 days, we start tapering the steroids. We come to bare minimum steroids. We don't overdo on steroids. In spite of on that, a lot of people are getting severe secondary infections, gram-negative infections, Acinetobacter, fungal infections, mucor, white, blue, black, all fungi we are getting. So COVID itself is an immune dysregulation. COVID causes immune dysregulation. It suppresses your immune system. So we do not want to overdo it. We do not want to give steroids. In this patient, what I would ideally give him is 1 tablet 2 days, 2 tablets 2 days, 1.5 tablets 2 days, 1 tablet 2 days, and I will just stop the steroids, taper it off fast. Then Ecosprin and Xarelto. Now, I'm going to come to this point in my next case. Now, anticoagulation in patients who are stabilizing, who do not want to have a lot of, there is a lot of risk of bleeding. In fact, you won't believe when we were managing COVID, almost 25% of my patients, in spite of giving only prophylactic dose 0.4 OD of Clexane in the wards, 25% of them had some evidence of clinical bleeding. Most of them hematuria, epistaxis, and then GI bleeds. Many of them had that. So anticoagulation, I would give only in patients who are really comorbid, who are bedridden, who are unable to move a lot. I would give anticoagulation, Xarelto, 10 mg OD for a month. Then in patients who are mobile, who are really doing well, stabilized, I would just give those 7 tablets. You get a strip of 7 tablets of Xarelto for a week, and then you stop anticoagulation. Then you can go back to Ecosprin, clopidogrel, or whatever he was taking in the past. Pirfenidone, now antifibrotics. I would really not recommend using antifibrotics. There are no guidelines mentioning this. We have a whole section on post-COVID fibrosis, which Poonam is going to talk on. Dr. Poonam is going to really elaborate on all these things, and she's going to show our data, what we have managed in the last 8-9 months. So pirfenidone, I would not give unless I do a really good PFT after 28 weeks. If PFT is showing moderate to severe restriction, patient is dependent on oxygen, patient has come out of really bad COVID ARDS or sepsis, and he was on mechanical ventilation or NIV for a long time, and then he recovered. Then I would think of giving fibrotics. That too, we don't know how far they help. There are no specific guidelines as of now. So I would not be giving pirfenidone. We have been giving pirfenidone for almost 8-9 years now, and we don't give 4 tablets a day. The ideal antifibrotic dose of pirfenidone is 9 tablets a day. It is 1,800 mg, or we are getting 801 pirfenidone now. You need to give 2,400 mg of pirfenidone. That too, it's a slow-acting drug. It's not that you give pirfenidone and then it is going to cause wonders. No. So for this patient, give him a good diet, good rest, encourage him, psychologically support him, pulmonary rehabilitation, breathing exercise is going to work wonders. After 3 to 6 weeks, most of these patients can be weaned off oxygen. Okay, now the third case is a 55-year-old female. There was a controversy about a month and a half back. In fact, this is a live case. One of the family practitioners from Bhandupet referred this lady to me, and I had made some statements that you don't need to give anticoagulants in patients who are stable and do not have any hypoxemia. I still stand by it, and I'm going to show you my data also, what I've said, what I have claimed. And she was on home isolation, absolutely stable. She had some comorbidities, diabetes, but old age. We did her CBC CRP D-dimer because she had some comorbidities, and then on 7th day it comes as 1,500 nanograms per ml. What will you do is my question. Please be ready for your polling. Start on blood thinners, Ecosprin. You will start on low molecular weight heparin on OPD basis. You will just observe the patient or admit saying she has an embolism. Shall we have the polling, please? Khalil bhai? Yes. So the polling will be on your screens. Please start polling in large numbers. Don't think. You want to admit her, you want to give low molecular weight heparin, you want to observe, or you want to give Ecosprin blood thinners. Tell me, what are you going to do? Very good. Only 60 people have polled. Where are the rest? 330 people are there in the meeting. Come on. Poll fast. We have finished 25-26 seconds. I thought within 10 seconds everybody would poll, but I think abhi nashta nahi hua hai. Come on, fast. 125. I think we should 5, 4, 3, 2, 1. We will stop the polling now. Stop. Can we have the results, please? Okay, excellent. So I want you all to observe. That is what I have been saying. I do not want you all to overdo on anticoagulants. I will show you all the evidence. Many people are saying start on low molecular heparin. A patient who is rock stable, not hypoxemic, saturation normal, no symptoms of any kind of DVT or pulmonary embolism, I would not give low molecular weight heparin. Blood thinners, ecosprin, no. A lot of cardiologists, a lot of physicians are advising, no, not required. We just have to observe this patient. Admit saying embolism, no. Now, D-dimer is an acute phase reactant. I will go back to my presentation. D-dimer is an acute phase reactant. It is an inflammatory marker. With any kind of inflammation, D-dimer is going to rise. What we have always been traditionally taught in our books is D-dimer has a very, very high negative predictive value. That means if D-dimer is less than 500, there is no evidence, there is no chance that the patient has had embolism or DVT. If it is more than 500, it has no meaning. Even a normal patient with some kind of abdominal pain may have a high D-dimer. We have had a couple of TB patients who underwent CBC, CRP, D-dimer, IL-6 and all, this IL-6, D-dimer, all these rise. He was TB, he had nothing else. He was coughing and his sputum was positive and he had a high D-dimer. So it doesn't mean that we are going to treat him with anticoagulants. Okay. So this patient, again, we repeated her D-dimer, which I wouldn't ideally advise. I also did this. It's not that I have not done this. I also did this. We did a D-dimer. It came out to be around 2,500. So now tell me again, start the polling. What are you going to do? Can we have the polling, please? Start low molecular weight heparin. Send the patient to the hospital for admission. Again, observe or give Xarelto 10 mg or Apixaban twice a day. Come on, poll in large numbers. Numbers are increasing. It's more than 330 people are there. And I'm hardly seeing only 100, 150 are polling. Rest are just listening. Doesn't matter even if you make mistake, it's fine. We all are also making mistakes. You can make mistake here, but not with the patients. Good. So we have finished 30 seconds. I think a few more seconds. 5, 4, 3, 2, 1. Let us stop the polling. Stop the polling, please. Can we have the results? Okay, now good. I'm happy. Still, many people are saying they are just going to observe. That is the absolute perfect answer. Send the hospital for admission. In COVID, there are only 2 indications of admission. One, if the patient has low saturation, if the oxygen goes below 93, 92, patient is feeling breathless, then I will immediately ask the patient to go and get admitted. Second is if fevers are not subsiding at the end of 7th or 8th day, and that too, not occasional fever, if the fever is just 102, 103, it's increasing, patient is frustrated, then you ask him to get admitted. We can give him good IV paracetamol, IV fluid, stabilize him. Otherwise, there is no indication for admission unless patient becomes really breathless and he has had some signs of DVT or something. So I will not ideally give Xarelto in this patient or Apixaban. No, that is not the correct option. Option is only to observe. This is what I have been telling from day one. That is what I have been practicing. So I'm going to show you my data, what we have done for the last 7-8 months. I could analyze data of 523 patients. I could get rest. My staff was not ready to take out the patient's data. Of these 76 patients, we had the data of D-dimer. All these were OPD patients. None of them got admitted. And see the results measure. Can you all see the slide? If it's visible, majority of the patients have a D-dimer of less than 500, but some have really high numbers, 3,500, 3,000, 2,000, right at the beginning. Some have 1,000, 1,500. It doesn't mean that it is going to, there is embolism. This is the second data. I don't think you will find this in any books. First few days when there's active viral replication is when the D-dimer shot up, saying this is an acute phase reactant, it's an inflammatory marker. Then D-dimer stabilized, sometimes even going down. Then again, the second week, there was again peak of D-dimer, if you can see. So patients, D-dimer went up to sometimes 10,000, 12,000 as well. So all these patients we really observed because they were not hypoxic, they were not showing any signs of pulmonary thromboembolism or DVT. We traced all these 76 patients, we called them back. Most of them had finished 3 months of their treatment. Few were on second month. And only one patient in the month of January had a left lower limb superficial tibial vein thrombosis. That time we had given her Xarelto. We thought it was post-COVID. I was feeling bad that I didn't give her anticoagulation in spite of having high D-dimers. But then after a month, she developed abdominal pain, irregular periods. her USG showed an ovarian malignancy, and after 15 days she got operated. So probably it was a malignancy which predisposed her for embolism and not COVID per se. So my take-home message is we need not do. So there are a lot of, these are NIH guidelines which are standardly used for practice in US and UK and Europe. They say there is insufficient data to recommend either for or against routine DVT screening in COVID-19 patients without signs or symptoms of thromboembolism, regardless of coagulation markers. Mind you, I'm talking of only non-admitted patients. Admitted patients, the moment he enters, steps into the hospital, I will give him a jab of low molecular weight heparin. This is for OPD patients. For non-hospitalized patients with COVID-19, anticoagulants, antiplatelet therapy should not be initiated unless the patient has signs of arterial thrombosis or other indications of therapy. So finally, I hope I've been able to give you some justice with my talk. There is one last thing. We all have heard of Mucor Mycosis. Many people have read it in papers and all, but we were fortunate to see one such patient. And this was the patient. Can we see the slides? Is it visible? Is the slide visible to everyone? So see, this patient came to a friend ENT of mine. She came with pansinusitis. We did an MRI, a CT scan. It showed pansinusitis. They were going to put a scope and see within second day. This is rapidly progressing fulminant. Can you see her eyes? She lost her vision within 2 days in her left eye, and unfortunately, she was at home. She had fever. No treatment taken. No tests were done. She was living alone. Suspected mucor, rapidly progressing. Saturation was all throughout normal. Her CT chest showed some COVID-like changes, so she was transferred under my case. Unfortunately, we couldn't do justice. Nobody was ready to operate her. We had to shift her to a higher center. And last which I heard was she was extremely critical, underwent 2 or 3 surgeries, and was on ventilator, not doing well. So this is what a mucor is, and this is what we can prevent. And I hope I've done justice by giving you certain things. We will be taking up your questions. Now we are short of time. I'm going to answer all your questions at the last 1 hour of question answer session. We have kept it specifically for this. Please be glued to your seats. And thank you very much for giving me a patient talk. Jai Hind, Jai Maharashtra.
Thank you, Dr. Subramanian Natarajan, for this lucid presentation and the practical insights which you have given us today. Next speaker is a renowned pulmonologist from United States, University of Florida, Miami. After graduating from the prestigious St. G.S. Medical College and KM Hospital, Dr. Hiren Mehta went on to do post-graduation in internal medicine and fellowship in pulmonary and critical care medicine. He presently is a director of the University of Florida Medical ICU and director of Interventional Pulmonology, United States. His special interests include lung nodules, interventional pulmonology, and lung cancers. He has multiple publications to his credits in international highly indexed journals. We request you to kindly be patient audience and please type your questions in the chat box option, and our moderators will direct the questions to Dr. Mehta. Please welcome Dr. Hiren Mehta, sir. Over to you, sir.
Hi, good morning, everyone. Can you see my screen? So I would like to thank you. So a special thank you to Dr. Subramanian Natarajan and the hosts for organizing such a great session. It's relatively past midnight here, so please don't mind the background and everything. But what my job today is to go over how we manage a COVID patients in the United States. And just like what you have done in India, we have learned so much over the last few months and years. And we have really changed our management based on what the guidelines have come out and the studies have come out. And what I want to do is I want to keep this session as interactive as possible, audience engagement, just like Dr. Natarajan did. And we'll go over some polling questions, we'll go over some guidelines, and see if we can learn from each other. So having said that, I'll get started. I really have no conflicts of interest when it comes to this talk. And these are my objectives. So management of COVID-19 as an outpatient, discuss the outpatient and inpatient treatment, and then discuss the therapies which can cause harm, and then the treatments which have no benefits. So none of you are surprised or none of you are unaware of this data. This is the data, most recent data from World Health Organization. This is from May 18th. And what we know is that globally, more than 163 million patients have been affected by COVID, and more than 3 million patients have died from COVID. And these are the waves which have come and gone. The most recent wave, as you can see in purple right here, was the one which was triggered by India, especially in the Southeast Asia region. And this is the graph that I really like. And everything that you're going to hear today, what Dr. Natarajan, the previous speaker, spoke about, is how do we manage the patients with COVID. And this is a beautiful graph which has been published by FDA based on the most recent evidence, and it takes you through where is your patient along this timeline and how do you treat these patients. And I'll come back to this as we move along my talk. And so I would like to start out with a case presentation. So I have, and this is a patient that it's the same patient, and I want you to take this patient from day one when this patient was exposed to COVID to how she ended up in the ICU and how she was treated. So we had a 70-year-old female who lived with her husband. She had diabetes, she had hypertension, and her husband was actually diagnosed with COVID. And so she calls our office and she was worried, rightly so. And she said, "What should I do? My husband's been exposed to COVID." But she herself at that point did not have any symptoms. And um, and so the question that of course comes up is, what do we do? She's extremely worried. She is elderly, some diabetes, she has some hypertension, and she lives in the same home as her husband who is diagnosed with COVID. Whether you would admit her to hospital and start her on oxygen and Plaquenil, or she stays in home in isolation, you get a CT scan, and if it's abnormal of the chest, then you admit her, or you start antibiotics and remdesivir at home. Can we please start the polling? So if you can see the polling on your screen, if you don't mind, please answer as many as like, just like Dr. Natarajan said, please um, participate, please engage. And I think it will be a good interactive session, and we can learn from what we do here and what you do over there. Let's stop polling. In the interest of time, I'm not going to keep holding the polling for long enough time. And so as all of you can see the results, most of you said the right thing. So I'll stop the share results, and then I'll move on to my next slide. And so, yes, let's see. Yes, the correct answer is you should keep them at home in isolation. There is no evidence to admit this patient to do anything. Just like Dr. Natarajan said, some of the theme of the talk that what you heard from the previous speaker, it's exactly going to be the same, is what works, what doesn't work, and what should we do and what should not do. And so, yes, so she was stayed at home, nothing happened to her. She was fine for a few days. And then a few days later, she calls and she says that now she's starting to have fevers. Although she's asymptomatic, just has mild limitations in her functional capacity. She's not short of breath, but has fever, cough, and is starting to have some body aches. And she calls us back again and says, you know what, you told me to stay at home. I've been staying at home. I'm doing isolation. And now I'm starting to have some symptoms. When you specifically ask her, how about your breathing? She says, my breathing's fine, but I'm starting to feel run down and I'm having fevers, coughs, and body aches. What would you do then? Let's start the poll as I read this. One is to continue to stay at home and monitor the symptoms. Second is to admit in hospital and start remdesivir, steroids, and antibiotics. Third is to start monoclonal antibodies as outpatient. And fourth is to obtain a CT scan and then manage based on the results of the CT scan. All right, let's please participate as many as even if I get to a third of the participants, I think that would be a win. That's great. Let's stop the polling here and let's share the results of the poll. So most of you said that continue to stay at home and monitor symptoms. And for most part, it's true. However, in the United States, over the last 6 months, what we have seen is we have seen that If there's anything we can do to prevent hospitalization and prevent ICU admission and prevent them from becoming severely or critically ill, we try to do that. And one of that thing is to start monoclonal antibodies as an outpatient. Now, correct me if I'm wrong, but I think some of these have been approved in India as well more recently, and they are available for injections. But these are the monoclonal antibodies which have been approved in United States. There are mainly two of them. One is the bamlanivimab, and the second is the casirivimab. The casirivimab imdevimab combination is also called Regeneron. That's the one that President Trump got when he was admitted with COVID. And the other one is the bamlanivimab, which has been approved as well. So what do these drugs do? So these are basically monoclonal antibodies which are available for infusion to these COVID patients. And there are two large studies which have been done to date. One is the Blaze trial, and the second is the um, Regeneron trial. And what they looked at is they looked at what do these drugs do, and they found is that when you give to symptomatic COVID patients who are not ill enough to be admitted in hospital, and if you look at this outcome data of hospitalizations and deaths at 20 days, these drugs actually decreased hospitalization or death by 70 to 90 percentage. And if you look at, these are the outcome data right here. So only 4 out of 511 patients who got the benvalinimab versus 15 out of 258 patients were actually who got placebo actually suffered from hospitalization or death. And the majority of the benefit, actually, believe it or not, was the death benefit, mortality benefit, and not the hospitalization benefit. The same thing with Regeneron drug is that patients, only 7 patients who got hospitalization or death who had COVID-19 and got this monoclonal antibody infusion, as compared to 24 patients who got placebo. And so who are at least in the United States, these are the guidelines. So patients who have mild to moderate COVID-19. So these are the patients who have confirmed COVID-19, and these are the patients who have positive test, a PCR test or an antigen test, and they are within 10 days of symptoms. So you cannot be after 10 days. So you have to be within 10 days. You are symptomatic but not sick enough to be hospitalized. So you absolutely do need to meet these 3 criteria, and then you should have one of the comorbidities. So either you should be above 65 years of age, or you should be on immunosuppression or CKD or diabetes or high BMI, or if you're above 55 years of age, then you should have cardiovascular, COPD, or hypertension. So if you go back to our patient, she's 70 years old, she has diabetes, she has hypertension, so she meets all the criteria. So she actually did get a dose of Regeneron. Now, how is this drug given? In the United States, these patients get IV infusion. It's a single infusion. So what they do is they come to an infusion center, the most local infusion center close to their house, and the drug is infused over 20 minutes to an hour. And then they're watched for additional 20 to 30 minutes for infusion reaction, and then they're discharged home. So it's a one-time dose. It's one drug, one infusion over 60 minutes, and that's it. And we talked about what are the benefits. So the benefit really is that they prevent hospitalization and they prevent deaths. And that's what we all want. If there's any way that we can keep these high risk patients who have COVID-19 outside hospital and prevent them from progression, then we should do that. And at least in my experience, I've given these drugs to 8 to 10 patients, and it really works well. It really keeps these patients out of the hospital. So going back to our patient, unfortunately, this was one of my patients who didn't respond very well to this drug. And on day eight, she calls back and she says her um, fevers and cough have subsided a little bit, but now she's starting to have some shortness of breath on minimal exertion. She's not short of breath at rest. So she comes to an office visit, and these are her vital signs. So I see the polls already open, but please start answering if you can see the polling. What do you do next? You admit her and start her on remdesivir. You admit her and start her on convalescent plasma in addition to remdesivir, or you admit her and start dexamethasone, convalescent plasma, and remdesivir, or you admit her to the floor and do full dose anticoagulation. I don't think after what Dr. Natarajan said in the first talk, I don't think any of would because he's kind of made it very clear that there is no role for anticoagulation. So let's see what the polling shows. Are the polls open? All right. Let's stop the poll if they're open, and let's share the results. Okay, so here are the results, and this is a tricky question. So a good number of you, a third of you said, let's admit them to the floor and start remdesivir, admit them to the hospital. And then equal number of patients said that admit them to the hospital and start remdesivir and dexamethasone. So I'm going to show some data onto what is the indication for dexamethasone. Most patients, it seems like most of you agree at this point we should admit the patient to hospital, which is correct. So I'll move on to my next slide. And so the correct answer is admit to hospital and start remdesivir. And so these are the recommendations for remdesivir. And remdesivir it's a drug which is, in my honest opinion, it has been hyped a lot. It has been given too much press, and it has been really, people have really tried to secure this drug and really tried to use this, where the data is actually weak, and the benefit, it has never been shown to cause mortality benefit. What it has shown is that it can decrease hospitalization and can decrease symptoms by a few days. So the Infectious Disease Society of America comes out with these guidelines on remdesivir. One is that in patients who are hospitalized with COVID-19, the Infectious Disease Society of America suggests that you should use remdesivir, or you may use remdesivir over no antiviral treatment, and defines severe COVID-19 as anyone who has oxygen saturation of 94 on room air or less. Again, they are very clear, and they say in patients who have COVID-19 who are on invasive mechanical ventilation or ECMO, you should not use remdesivir. In patients who are on supplemental oxygen but not on mechanical ventilation or ECMO, there are again studies have shown 10 days, 5 days, things like that. But the most recent studies have shown that 5 days of remdesivir is as good as 10 days. And so most guidelines here recommend that 5 days is sufficient. You don't have to go all the way to 10 days. And again, in patients who are not admitted in hospital, again, we should not be giving them remdesivir. So remdesivir is only if your oxygen saturation is less than 94 percentage on room air. If it's more than 94 percentage, even if you're hospitalized or you are not hospitalized and you're at home, there is no indication for remdesivir. So if somebody, like Dr. Natarajan was saying, gets admitted to the hospital with COVID-19 with persistent fevers, but their oxygen saturation is still more than 94% on room air, Infectious Disease Society of America recommends against remdesivir. So remember, the only indication for remdesivir is if you get admitted in the hospital, not critically ill, and your oxygen saturation is less than or equal to 94% on room air. And this is the typical timeline of COVID-19, and all of you have seen this in your patients, is that there is an incubation period, then there is a symptomatic phase. So if you go back to our patient, she had an incubation period, then she had a symptomatic phase here where she did not have hypoxia or oxygen desaturation or shortness of breath, but she had non-specific symptoms. At this point, she got her Regeneron. She, however, progressed, and she was admitted here with dyspnea on day 7, which is very common. People start having shortness of breath on day 7 to day 8. And so she was admitted here in hospital. She got remdesivir. And 40% of patients who develop symptoms will have dyspnea. Only 5% of them will be critically ill. So she gets admitted to hospital. She gets remdesivir. She does not get steroids. She gets prophylactic heparin, nothing else. And she was doing okay for a couple of days. However, on day 10, which is the second day of her hospitalization, she starts having more shortness of breath. And now her oxygen saturations are, remember, she was 94% on room air or 93% on room air. Now she's down to 88, 87% on room air, and she needs 2 to 3 liters of nasal cannula to keep her oxygen levels above 90%. What would you do next? And let's open up the polls as I read the answers or options. So one is we transfer the patient to ICU, and sorry, I'm just going to read my options. So transfer it to ICU and start steroids, tocilizumab, which is an anti-IL-6 medication, and continue remdesivir. Start convalescent plasma, dexamethasone in addition to remdesivir, dexamethasone in addition to remdesivir, or full dose anticoagulation in addition to steroids and remdesivir. I'll give 5 more seconds and then we will stop the polling. So let's stop the polling here and see what people have to say, what the group says. All right, let's share the results. All right, so pretty equally divided. The group is very divided on this one. So a third of you say that transfer the patient to ICU and start steroids, tocilizumab, and remdesivir. Some of you do say convalescent plasma. Most of you agree that we should start dexamethasone at that point. And then some of you still say steroids and full dose anticoagulation. So the correct answer, let's see if we can stop the polling here, and I'll move on to my next slide. And the correct answer is to start dexamethasone in addition to remdesivir. Um, I know that I just want to highlight a couple of answers because it seems like the group was evenly divided. One is to transfer to ICU. She's sick. Trust me, she's sick. But at least in United States, if you're on 2 to 3 liters of oxygen, you're not going to be transferred to MICU. Especially when we managed massive surges and we had no ICU beds and we had to expand into other ICUs and things. We were trying to keep these patients on the floors and not transfer them to ICU as much as possible. So at this point, she might be a little too early and not too sick to be transferred to ICU. Um, Convalescent plasma really has no role, and I'll go over that in a little bit. Dexamethasone, in addition to remdesivir, is the correct answer. And there is no role for full dose anticoagulation in absence of a strong indication. Just being sick and requiring oxygen is not an indication for full dose anticoagulation. Certainly, prophylactic anticoagulation is something that we would recommend. So back to our graph right here, and this is a little confusing. So when do you start steroids? And the timing, it's all about the timing. You want to start steroids early enough so that you can give them mortality benefit, but you don't want to start them too early so that you can cause more. So in that case, you can cause more harm. So if you look at the FDA guidelines, they say that once your patient's hospitalized, and if they're not on oxygen, so that means their oxygen saturations are less than 94%, but they're not less than 88. That's on remdesivir, but not steroids. As soon as your hospitalized patient needs oxygen, that's when dexamethasone comes into picture right here. And so this patient right here, when was first admitted, was on oxygen saturation 93%, but not requiring supplemental oxygen. And so at that point, remdesivir was indicated, but dexamethasone comes into picture when you are sick enough that you need supplemental oxygen. And that's why here are some of the definitions which we use on a daily basis, which are key. So somebody who is outpatient or inpatient but admitted with fevers but has no hypoxia, which is defined as saturation of more than 94, not requiring supplemental oxygen, is considered to be non-severe. Somebody who requires whose oxygen saturation is less than 94% on room air is considered to be severe. And then the severe is further classified into whether you have less than 94% on room air but not requiring supplemental oxygen, or less than 94% on room air but requiring supplemental oxygen to keep your saturations above 88. And that's where you would start steroids. And then critical illness is easy when you are on mechanical ventilation or ECMO. And so what are the recommendations for dexamethasone? So I know that when I was following the chat, when Dr. Natarajan was talking about it, a lot of you had questions about what is the correct dosing and how long we should give it for. So this is what the Infectious Disease Society of America recommends, and this is based on the recovery trial, which says that in critically ill patients, you should do dexamethasone 6 milligrams IV or PO daily for 10 days. There is no role for steroid taper. Steroid taper is not recommended. 10 days of dexamethasone does not need taper. So 6 milligrams IV or PO daily for 10 days is what's recommended. In severe but non-critical illness, you should strongly consider it. Amongst hospitalized patients who are non-severe or who are outpatients, glucocorticoids should not be considered. And the next slide will show you the reason why. So this is the subgroup analysis, which was of the recovery trial in New England Journal of Medicine in 2021. And this is what we found in this study. So if you have a critically ill patient, that means your patient is requiring non-invasive ventilation, high flow mechanical ventilation. If you give them dexamethasone, look at the odds ratio here. You can prevent mortality. You can prevent them from dying right here. But the odds ratio is 0.66, which is anything less than 1 suggests mortality benefit. If you have a patient, the second group of patient, there were 454 patients in the recovery trial who were requiring oxygen to keep their oxygen levels above 88, but not critically ill requiring ICU admission. The relative risk of mortality in those patients when you gave them steroids was 0.83 when you compare to placebo. What that means is that, yes, you can still prevent mortality on this patient. However, the benefit is not as good as when you are in the intensive care unit or when you're critically ill. But what I wanted to bring your attention to is the third group right here. So there were 500 patients in this group who received steroids. So these are the patients who are hospitalized in hospital, but their oxygen saturations are 90, not requiring oxygen. So their saturations are 94 or less on room air, but above 88, not requiring such supplemental oxygen. On these patients, when you give them steroids, you look at the relative risk right here. They die more as compared to placebo. So you can actually kill patients if you give them dexamethasone who are not ill to either be hospitalized, or they are hospitalized but their oxygen saturations are not low enough to require supplemental oxygen to keep their saturations above 88. So this is something that's critical, that we have to understand, that one size does not fit all. That's why we are physicians. We are supposed to risk stratify them, and we are supposed to decide who will and who will not benefit from steroids. So moving on to the next slide, unfortunately, this patient continued to decline, and day 12, she was on high risk, high supplemental oxygen. She was started on high flow oxygen at that point. She was on 60% FiO2, 60 liters per minute flow, and non-invasive ventilation, and she was transferred to the medical ICU. What would you do at this point? Let's open up the polling. First option is to intubate the patient, as invasive mechanical ventilation is better than high flow and non-invasive ventilation. Second is to continue dexamethasone and add tocilizumab, which is an anti-IL-6 medication. And at that point, you consider stopping remdesivir. Don't change anything, continue dexamethasone and supportive care. And again, we go back to the add full dose anticoagulation, which I think by the end of this talk, the message would be very clear that there is no indication for prophylactic anticoagulation for full dose. You can still do the standard dose prophylaxis. So let's continue to poll. Let's give 5 more seconds, and then we will stop the polling and share the results. All right, let's stop the polling here and see what we got. All right, so again, a very divided group right here. Again, I think everybody gets the point that anticoagulation is not an option of full dose anticoagulation, which don't get me wrong, all these patients should get prophylactic anticoagulation, which is either sub-Q heparin, low molecular weight heparin of 40 milligrams once a day, or they should get standard heparin 7,500 sub-Q Q8 hours, but not full dose. Okay, so 25% said intubate, as intubation is better than mechanical ventilation is better than high flow. Some of them say, third of you say continue dexamethasone, but add tocilizumab and consider stopping remdesivir, and a third of you say no change in treatment. So I think it probably, and I think I can see why the results are evenly divided, is because it probably is not a standard practice to give anti-IL-6 medications in India. But over here in United States, but there was a new study which was published 2 months ago. It's called a Remap Cap Trial, which was looking at anti-IL-6 medications in patients with severe COVID-19 who are critically ill and admitted to the medical ICU, and it actually showed that it improves mortality when it's given in addition to dexamethasone. So in United States, once a patient with severe COVID-19 ends up in the medical ICU who is already on dexamethasone, we add tocilizumab at that point. And we stop, if they were not started on remdesivir, then we do not start remdesivir on these patients. And if they already were on remdesivir, we stop remdesivir at that point. And the reason is remdesivir at that point is not beneficial when you are critically ill, and you may cause some hepatotoxicity and things like that when you start adding multiple medications. And so to bring, I think a third of you responded saying at this point you intubate the patient. Unfortunately, we debate this all the time. There is very little data showing that early intubation is better in these patients. In fact, some people argue that if you can sustain them without being intubated for as long as you could, then you should try to, because intubation itself causes ventilation-induced lung injury. So what I'm trying to say is that early intubation is not better than high flow oxygen or non-invasive ventilation. And so these are the guidelines for tocilizumab or baricitinib. Both of them are anti-IL-6 therapy. And so in patients with ICU who have confirmed COVID, who are receiving concomitant steroids and are within 3 days of hospitalization and a progressive respiratory failure, you should consider, based on the Remap Cap trial, starting them on tocilizumab. In non-ICU patients, in addition to all the above findings, they should have a CRP level of more than 75, which is a marker of inflammation, which is a marker of cytokine storm. And that's what you're trying to suppress with anti-IL-6 medication, is that cytokine storm, which the initial phase is phase, the next phase is the cytokine storm phase. And if you can suppress the cytokine storm phase, then maybe you can prevent them from having fibrotic lung disease and mechanical ventilation for prolonged period of time. So that's the thought, and those are the guidelines for tocilizumab. Again, these are the contraindications for tocilizumab, as I mentioned down there. And um, and so our patient did get tocilizumab, and unfortunately, she continued to deteriorate, continued to decompensate, was intubated. Her PaO2 to FiO2 ratio at 4 hours post intubation was 88. She was on 90% FiO2 and a PEEP of 18. Let's open up the poll and see what the group would do for next steps. She's intubated. She's on prone position. She's on high FiO2. Her PF ratios are terrible. So A is prone position ventilation. Second is start inhaled Flolan or inhaled nitric oxide. Consider veno-venous ECMO, or have family discussions about goals of care and how to progress. All of the above. I think this is actually a very specialized question, and I can understand a lot of you don't manage this very critically ill patients in the intensive care unit. So you can pick your guess. No one would know what you answered, so who cares, right? Just click something. All right, let's stop polling at this point. And the correct answer is, yeah, at this point, there is nothing to lose. I think all of the above. So our lady right here, she got all of the above. So she basically was prone position. So she received prone position for 48 hours. She was not getting any better. She was on inhaled nitric oxide. And at that point, we were having constant discussion with the family for goals of care. And unfortunately, she passed over a few days, like over next few days. But we have had several patients. To date, we have done veno-venous ECMO on 80 patients with COVID-19 in the last year. And our center, and once you get on veno-venous ECMO, it's really a bridge. It cannot be by itself. It has to be a bridge to something, and it has to be a bridge to lung transplantation. So when you put somebody on veno-venous ECMO, you have to understand that the next step might be lung transplant. And so to date, we have done 80 veno-venous ECMOs on these patients, and we have transplanted 16 patients with COVID-19 with bilateral double lung transplants. Our center, University of Florida, has the highest number of lung transplant for COVID-19 in the world. So we did the second lung transplant for COVID-19 patients in the world. So the first was done in Northwestern in Chicago. The second patient with COVID-19 lung transplantation was done at University of Florida. And to date, we have done the most number of lung transplant for COVID-19 in the world. She was, however, too elderly and too fragile and had multiple comorbidities, and she would not have been a candidate for lung transplant. But people in 40s and 50s, we have offered them lung transplants. So having said that, I'm going to quickly go over the therapies which have shown no benefit but have shown harm in patients with COVID-19. So Plaquenil with or without azithromycin, lopinavir ritonavir combination. The harms that they cause is they cause prolonged QT, they cause GI side effects, and they don't have any benefits. The one thing that I wanted to bring to everybody's attention is steroids in non-severe illness. So if you are at home with COVID-19, or if you are admitted but your oxygen levels are still good enough that you're not requiring supplemental oxygen, please do not give steroids. You can actually kill your patients. And then convalescent plasma, there was a lot of buzz about convalescent plasma in the initial phase when the COVID first hit. As we did more and more, we realized that it doesn't benefit. If anything, it causes harm, it causes volume overloads, it causes acute lung injury and transfusion reactions. So please don't use that. And then full dose or intermediate dose anticoagulation, do not use that. Studies have shown the mortality is similar when you do intermediate or full dose. Empirically, similar rates of DVTs and thrombosis and significantly increased risk of bleeding. And then these are the treatments which have shown no benefit. So ivermectin has shown no benefit, Pepcid's not of any benefit, antiretroviral therapies of no benefit. Remdesivir in critically ill patients, once you are ill enough to be on high flow oxygen or you are ill enough to be intubated, remdesivir has no role at that point. And then monoclonal antibodies that we talked about, but in the admitted patients, it has only been shown to work as an outpatient because the entire purpose is to prevent hospitalization. Once you're already hospitalized, monoclonal antibody is of no benefit. So I didn't want to take much time, and I hope I left some time for discussions and questions. But one thing that I will tell you, my personal experience, we had our first patient of COVID-19 in February of 2019, and here we are a year and a half later, or February 2020, and here we are a year and a half later, and we have learned a lot about COVID. The most important thing that I have learned, my personal experience, is that the one thing that works is supportive care. Good supportive care is what works. A lot of other things, we started out, COVID-19 started, we started with plaquenil, we started with ACE inhibitors, we started with convalescent plasmas, we started with giving mm, tocilizumab to everybody, anti-IL-6 medications. We started giving them antibiotics, broad spectrum antibiotics. We did a lot of things which we eventually learned causes harm, and we actually might be killing more patients than causing benefit. So my request to everybody here on the group is, our job as a physicians, our Hippocrates oath says that first do no harm, and that should be our motto. Is if we can't help our patients, let's not harm them. And one of the biggest things which causes harm in these patients is polypharmacy, giving them medication that doesn't work. What works is a good supportive care, and then what we talked about. And what we do know works is vaccine. I can tell you, like, I have seen our peak was in December and January and February of this year. And then as the vaccines were launched, we have seen such a dramatic decrease in hospitalization and number of cases. Doesn't matter what vaccine it is, please vaccinate. Please pass on the message. Please pass on the message to your patients, to your families, to your friends. Please vaccinate. We can get over this together with vaccination. I'll stop
Dr.
my slides and
Yeah.
yes.
Dr. Mehta, it was a wonderful lecture, and we would really give you a thumbs up for this. And there are a lot of questions, but for the interest of time, I'm going to restrict the questions. Dr. Meenal Patil has asked, would you prefer dexamethasone over methylprednisolone? If not, why? If yes, why?
So that's a good question. We do dexamethasone because the recovery trial used dexamethasone, but there is no strict guideline that dexamethasone is the only steroid which should be used. As long as you're using a good steroid conversion formulas and using equivalent doses of any steroids for that matter, it should work. The only advantage of dexamethasone is it also, along with the glucocorticoid effect, it has a little bit of mineralocorticoid effect, which methylprednisolone and prednisone does not. And maybe that's why it's more beneficial. So I would recommend that if you have dexamethasone, use dexamethasone, but any steroid would work as long as you are having the right conversion doses.
Okay. One Dr. Sudharma Darvi, she has asked this advantage of vaccination you have observed. Is it true that incidence of getting infected as well as reduction in severity has been observed in United States? Because in India, we have vaccinated very few people as per 100 million per 100 of population.
I will tell you that vaccinations work, and there is a common so once we started, so I was one of the first ones who got vaccinated in the United States. I got my vaccine in December of the last year, and we have seen dramatic decrease in hospitalizations, surges, mortality. Even today, like right now, we have like 10 patients with COVID-19 in our medical ICU. All of them are not vaccinated. None of them are vaccinated. We have not seen vaccinated patient admitted in the medical ICU over the last 3 months. And none of the vaccine is superior than the other. All of them work. So there is a common misconception that maybe the Pfizer is better than the Moderna, which is better than AstraZeneca. No, like I have very close friends in the United Kingdom who all of them get AstraZeneca vaccine, and they have seen significant decrease in their surge after getting AstraZeneca vaccine. So please vaccinate.
Okay, now another question is by Dr. Patil, whether early active intervention in elderly comorbidities, elderly with comorbidities is what you would advise in spite of being asymptomatic, is what you are going to advise if the patient is asymptomatic. What is your advice?
So for asymptomatic patient, no intervention is needed. For mildly symptomatic patients, the guidelines suggest that monoclonal antibodies in elderly patients with comorbidities, if you have symptoms but not respiratory distress and you're not admitted in the hospital, monoclonal antibodies can prevent hospitalization and death.
Okay.
So the
That's
Regeneron
great.
combination or the Bevacizumab combination.
That's great. So we have that combination available here in India as well. And I was fortunate to give it to in one of the patients in Mumbai, whole of Mumbai, hardly 15 to 20 patients have been given. And in one of the hospitals where I go, we have given it to one patient. She was diabetic. She was 45 plus. She has hypertensive IHD. We could prevent admission in her. Her father died. Her sister died, but she didn't even have to get admitted.
Yeah.
Now that may work.
Yeah.
Of course, the cost is a
Electronic
limiting
medication.
factor. And one final question is Dr. Yogesh Yerolkar and Dr. Ashwin Joginder, sorry, they've asked what is the lung transplantation success in Florida, and what is the life expectancy after lung transplant in COVID per se?
So as you know, it's very early, so we don't know. We have transplanted 16 patients so far with COVID-19. All of them are doing great. One of them actually who's not doing very well is the one who got combination of lung and kidney transplant because he had also had acute renal failure. And he's still outpatient. Now, this guy was on ECMO, so it's all relative. He's still requiring supplemental oxygen or 2 to 3 liters, but it's better than being on ECMO for a month. So he's alive. So far, early data shows that it's a remarkable success, and we actually published our data in Lancet Respiratory Medicine.
Okay, one last question is, we have been giving antifibrotics in and out. Every patient who steps into the hospital, before even steroid is given, pirfenidone is being given here. So what is your recommendation, and what is the data? What is practiced in US? Please throw some light on it.
So in the United States, nobody would get pirfenidone for post-COVID fibrosis. Post-COVID fibrosis is an entity, all of us recognize it, but none of the studies there is no data showing that antifibrotic medications work against post-COVID fibrosis. And so none of the guidelines recommend it. There are 2 large studies which are going on right now, which are randomizing patients with post-COVID fibrosis to pirfenidone versus placebo. So we will see what the results show. We should have some results in the next 6 months to a year. But like we have said over and over, that if you want to do something, then might as well do it in a large clinical trial setting, because the last thing you want to do is to cause harm for the benefit, which may be minimal. And as Dr. Natarajan, you know this, the benefit of pirfenidone, even for approved indication is minimal. It's not a game changer medication. So I don't know whether we should do it. And my recommendation would be to not do it till the large data come out.
Many thanks, Dr. Hiren Mehta. Dr. Tina, please take over.
Thank you very much for inviting me. My pleasure.
We thank Dr. Hiren Mehta sir wholeheartedly for having enlightened us with a glimpse of COVID management in United States, in spite of being 12 midnight there at Florida. Thank you so much once again, sir. We would like to request all the newly joined delegates, please log in with your full name, which will help us to give you MMC credit points. Now, we would like to call, before we move on to our next session, we would like to call Dr. Santosh Kadam, IMA President Thane, who will do lamp lighting on behalf of Dr. J.A. Jayalal, National President, CGP IMA. Dr. Ram Chandwani sir, IMA Thane, Chairman, will do lamp lighting on behalf of Dr. Jayesh Lele, Honorary Secretary General IMA. Dr. Jayesh Boricha, IMA Thane, CGP Secretary, will do lamp lighting on behalf of Dr. Ramakrishna Londe, President IMA Maharashtra States. Dr. Rajan Joshi will do lamp lighting on behalf of Dr. Pankaj Bhandarkar, Secretary IMA Maharashtra State.
Good morning, friends. Hello, Dr. Ya.
We are indeed privileged that all these dignitaries are a part of our CME today. So with this, I would like to hand over the proceeding to Dr. Santosh Kadam sir. Over to you, sir.
Thank you. Good morning and welcome all the delegates, all my IMA friends all over Maharashtra, as well as a few of our Ayush doctors who have joined for today's CME. I'm very happy that we have crossed registrations more than 1200 and now closed the registrations. Friends, from platform of IMA Thane, along with Lung Center, we are doing such kind of respiratory update CME every year for past few years. Dr. Poonam and Poonam Subramanian Natarajan are the ethically practicing couple from my branch, and they are practicing for last 10 years. Let me tell you, as our Honorable President J. Jayalal, National President, has joined, Secretary General Dr. J. Sele has joined, Dr. Ramkrishna Londe, President IMA Thane has joined, and Dr. Pankaj Bandarkar, Secretary Maharashtra State IMA joining. We have done lamplighting on their behalf, and I'm very happy that today we have with us our Honorable President. Regarding my branch, friends, now my branch has crossed 1300 registration and has become the fifth largest branch in Maharashtra state, and we are very happy, and we are looking forward to host Dr. J.S. Lele sir is here to host MasterCon and the installation ceremony for the incoming president, Dr. Suhas Pillai. We would like to do it from our Thane IMA hall and Thane city. With this, Thane city is growing leaps and bounds. Jayalal sir, let me tell you, this Thane district is the biggest district in India till few years back. Now it is divided into two districts, that is Thane and Palghar. The population of Thane district is around 80 lakhs and having almost 6 corporations. And in Thane districts, we have almost 15 to 20 branches, which are very, very big branches. So with this short introduction, may I invite Dr. J. A. Jayalal, National President of IMA Thane, to address the gathering.
Thank you. Thank you very much and good morning. Respected President of this prestigious branch of Indian Medical Association, IMA Thane, Dr. Santosh Kadam, the Honorary Secretary General of Indian Medical Association, Dr. J.S. Lele, my beloved leader of IMA Maharashtra, Dr. Londe, the Lung Center, the Dr. Poonam Subramanian, and the distinguished members of Indian Medical Association of the Pune, of Thane and Maharashtra. I'm extremely happy and delighted to be the part of this your 7th Respiratory Update program organized by IMA Thane and the Lung Center. I am delighted that Indian Medical Association not only helps the doctors in their professional updation, in their social well-being, and then their personal, the integrity and the lifestyle modification. But we are mainly now focusing more on the academic empowerment. The empowerment of knowledge and skill to every doctor of this country is a need of the hour, as we have now entering into the predictably unpredictable COVID and all other epidemic disorders in this country and the lifestyle diseases. It is necessary that every doctor of our country is empowered with updated skills and knowledge. For that, Indian Medical Association is very much focusing on the seminars, webinars, and various programs. I'm delighted to see that IMA Thane, in association with the Lung Center, is able to organize the respiratory update program continuously. I'm happy to note that it is a 7th day. And integrating IMA with then the ethical hospitals is one of the good steps and need of the hour at this moment. IMA has a base, IMA has a platform, and we need to incorporate various corporate hospitals. Various hospitals are working with ethically in a better way to encourage them and to integrate with them. And such programs will be always a beneficial one. I know I could see when more than 400 people have joined in the program, that shows the commitment of both the Lung Center in their work towards the community and the ability of Dr. Santosh Kadam to incorporate and have a good relationship with all the hospitals in Thane. I'm so happy to know from you that Thane is was the largest district, and today we are having it is divided into two, and more than 1,300 members are there in Thane, and in all the programs which Indian Medical Associations launched, and Thane has very actively participated, both in the recently held protest to seeking the government intervention to have the Save the Saviors program, or the previously the mixopathy issues, and all the programs. I am getting the report that the Thane is actively participating. I would like to wholeheartedly congratulate you on that issue. And today on the CME topic also, there was a wonderful discussion. I just had a glimpse of the talks at the end of the previous session, and where the one of the best way to conduct the CME is having incorporating it with the polls or the CME polls which was conducted, and that will always allow the participants to actively involve and understand it well and have the explanation from the experts on this field. And on this count, that we very recently we conducted a similar kind of program with the AIMS and Ministry of Health also, that we are working on, that we will continue to do such a structured program with the Ministry of Health and along with the AIMS and other expert hospital to update our members on the COVID care. So I take this opportunity once again, wholeheartedly congratulate Dr. Santosh Kadam and team, and also Dr. Poonam Subramanian and team for coming together and trying to give this best knowledge to the doctors. Indian Medical Associations always believes whenever the knowledge or the skill is given to a doctor, it is not going to stop short with the doctor. It is going to be percolated to the community, and ultimately the beneficiary is going to be the patient or the community. So whatever the CME program Indian Medical Association is doing, it is not only for the skill enhancements of our doctors, but for the social corporate responsibility of Indian Medical Association, because what the knowledge the doctor gains will be translated into treatment for the patient, and ultimate beneficiary will be him. So we are doing the CME programs for the concept of the social welfare or the social development. So I am very much delighted as a president of Indian Medical Association to participate in more and more CME programs, because I believe, and that is going to change the face of the healthcare delivery in this country. If you see the COVID today, because of this widespread webinars we are able to conduct, widespread knowledge which we are able to disseminate to the people, comparing with any Western countries, our mortality rate on COVID is phenomenally low. It is still, now it is 1.3%. Most of other countries, except Turkey, all have more than 2 as a mortality. That is a great credit or great way that it shows the Indian doctors or Indian medical fraternity is able to cope up with the situation by their enhanced knowledge. It is not only that one of the beauty of India is, even when she is a gynecologist, even she is a neurologist, even she is a pediatrician, they know much more on COVID care than any other experts which we are doing the COVID in other Western countries. That is the hallmark of even an obstetrician now today will be able to face the COVID people in a much better way. That because of Indian Medical Association, which is a conglomeration of all specialty, was able to give this knowledge and skill to the people. And that count, I once again appreciate Thane, more so my good friend Dr. Londe, the very, very dynamic state president of Indian Medical Association Maharashtra. Always I am seeing him touring. Every day I am getting report from that. I am starting so much of branch, sir. I am visiting these people. Very, very dynamic person. And it is credit and privilege for every member of Maharashtra. You are given one of the most dynamic person as a Secretary General of Indian Medical Association. Very meticulous, very, very straightforward, positive thinking person the Maharashtra has given. So at this moment, I would like to thank Maharashtra for contributing such a leaders to Indian Medical Association. I do hope and expect Dr. Santosh Kadam will also rise to that occasion. He will also come out of state branch and come to the national forum on the state forum. I give my best wishes for your programs of conducting the next Masticon and other events. So thank you very much. I wish all the best from the national headquarters for the entire people who are participating in this program. Thank you, sir.
Thank you, J. Jayalal sir, and we are really looking forward that we will invite you for our branch, and we are looking forward that you will visit physically in Thane soon, and you will accept our hospitality also.
Sure, sure.
Moving on to further, may I request our Honorary Secretary General, Dr. J. Lele, to address in short. Sir, unmute yourself. Yes, done.
Thank you, Dr. Santosh. Thank you, our respected national president, for so kind words. And really, I'm thankful to you for. I mean, of course, your words are very nice to me, and you're really we have appreciated my efforts along with the other IMA leaders. Dr. Santosh and Dr. Ramkrishna Londe, our Maharashtra president, he is always touring. Now also I saw him in a car traveling some place. And really, even if he's coming from a small area, but then he's doing a lot of hard work. And sir, just to tell you, Dr. Santosh was our MMC member also in our previous this thing, and he was done a very good work. He has brought Thane beyond a small branch to the big branch now. Thane is considered in our area as a big branch. And of course, activity-wise, every week there is a CME program in Thane, and really it is appreciated. In fact, I have attended many times in Thane, and I talked with regarding our HBI matters and other things, hospital matters. Myself, Mangesh, have visited there. Of course, to talk about the very important this today's lung center program with the 7th educational activity. Really, it's important because now we are anticipating that kind of a third wave. Some people are saying that it will be affecting this. Vaccines are not complete. Yes, but then our all our IMA members and the doctor community is very well equipped to treat the corona in a very strong way because our hard work is there. And unfortunately, in the bargain, we have lost 1,500 doctors across India, which is, I think, probably if you compare to the other areas, other countries, I don't think such a so big doctor community has been expiring in during this COVID issue. And of course, we are talking to the government. This very important taking matter, and this has really. It is a sad for all of us to have losing so many doctor community. Very important. Some of the young doctors and couples have expired during the fight against this corona war. Of course, we are all are prepared during the vaccination. IMA has completely supported. Even Thane is that. Fortunately, I have seen the Thane office and their hall. They are working good things with Rotary also. And in fact, they have a lot of joint programs along with the other social organizations and the neighboring organizations. Definitely, the Thana Mastakon, I still remember, which was Adao sir's time when Nalaude was a Punjabi was installed as a Maharashtra president that time. But even then, now let us see how the things work. This year, we are not sure what kind of a Mastacon we are going to have still because of the CME still not physically allowed in Mumbai. Because Mumbai, Thane is a very strong area where the lot of COVID cases are still there. In fact, yesterday also we had almost 11,000 COVID cases in this thing area. Let us see. But yes, regarding talking about the IMA activities, Dr. Santosh, I would also request you to participate on 1st July. Doctors Day is a big program in the afternoon. And 1 week Safe Motherhood program week we are organizing. And a lot of good activities will be there. So I would request you all to participate. Your wife also being a nephrologist, she also would be very happy to join this activity of the women's wing and other wing also. And as Dr. Jayalal sir, Dr. Mangesh is a very, Dr. Santosh is a very active in HBI also in our Maharashtra. So I'm really happy that the Thane IMA doing this good center CME activities throughout the year. And I wish the entire Thane IMA my great wishes, and whatever help you need from the IMA headquarters, we will be more than willing to help you, whether it's a CME or any other format. Please inform us, please tell us, and we will definitely join all your good programs. Thank you so much, Dr. Santosh, for inviting us. Thank you for giving us the opportunity for talking to all the members today. Thank you.
Thank you, Lele sir. We'll definitely will join all the activities, whatever you are advising at national level. Dr. Ramkrishna Londe has joined. He's on a tour to Western Maharashtra. I think he's not there. And Dr. Pankaj Pandarkar is also on the tour. So both of them cannot join. So with this, we will sum up the inauguration ceremony over here. And let's move on to the academic activity. And thanks, Dr. Jayalal sir and Jayesh Lele sir for joining for the inauguration ceremony. Over to you, Dr. Poonam. Dr. Poonam, you can take over the proceedings now. Dr. Natarajan. Volume band. Sound band. Okay.
We wholeheartedly thank all the dignitaries for having graced the occasion and addressing the audience and wishing us a grand success. Moving on to our next speaker, Dr. Poonam Subramanian. Our very own Dr. Poonam Subramanian, an established pulmonologist in Thane, is very well known amongst medical circles. Smart, suave, witty, and knowledgeable. Dr. Poonam, with her excellent communication skills, she is known to enthrall the audience and keep them glued to their seats. She is going to discuss COVID cases with all of you. Please welcome Dr. Poonam Subramanian. Over to you, ma'am.
Okay, so very hearty good morning to all my respected doctors and dear colleagues. This is Dr. Poonam Subramanian here, and after a long hiatus in the year 2020, we are back with a bang in the year 2021. This has only been possible due to your continued love and support, due to which we managed a staggering number of 1,200 registrations today. And this is indeed a very, very big figure for us. And though we are meeting virtually, I'm sure that you're finding the sessions as enriching as our previous ones. So with a lot of gratitude in my heart and a smile on my lips, I would definitely begin my case discussions in COVID today. So my first case is of a 55-year-old male who was admitted for COVID-19 pneumonia in a COVID hospital. He was given remdesivir and steroids. He was mildly tachypneic and he required oxygen of around 2 to 4 liters by nasal prongs. His CT scan was done on day 1st. His RT-PCR was positive, but his CT scans were subsequently repeated on the 7th, 11th, and the 14th day. I will just show you the picture of the CT scans. So this was the first CT scan, which was done on 2nd April. You can see a CT score of 13 out of 25. The second CT scan was repeated on 8th. It was showing a CT score of 14. Then subsequently, the CT scores increased to 15 and then to 16. So before I put forth my question, again, please remember that we are having a poll here and you are supposed to answer. So please answer enthusiastically. But before that, I would like to ask you a question that were all these CT scans warranted? So as our previous speakers have also said that CT scans, if a patient is having RT-PCR positive, there is no need to do repeated CT scans. A CT score, if we are showing a patient, okay, CT score is 13. Nowadays, patients come to us saying that, madam, my score is 13, my square is 12. So what should I do? So should I get admitted? So we are emphasizing again and again that please don't go by the CT score, go by the clinical stage of the patient, whether the patient is tachypneic, whether he is requiring oxygen, and you monitor him clinically also. Nevertheless, we always do x-rays when the patient is admitted. We always repeat the x-rays every 48 to 72 hours. So we know every 48 hours if we are repeating that the CT, that the x-ray picture is worsening. So we know, and if the patient is definitely showing signs of deterioration, then it is a clear-cut indication that he needs further management. But doing a CT scan usually does not provide any additional information, and in fact it exposes the patient to a lot of radiation risk. So please, it's a request that please don't do repeated CT scans. The CT changes as well as the X-ray changes persist for quite some time, so it takes around maybe 2 months, 3 months for the CT scans to improve. So even if you do the CT scan at the end of 1 month and the patient is sitting at home nicely, then also the CT score will be high. So please don't do recurrent CT scans. And now I'll put forth my question. So in this patient who is stable, who is requiring only minimal amounts of oxygen, and he's mildly tachypneic, but his CT score is increasing and his CT scan is worsening. So what will you do in such a patient? Whether you will monitor his interleukin-6 levels and give him tocilizumab, or whether you will give him supportive care, physiotherapy, breathing exercises, and good pulmonary rehabilitation, or will you start the patient on antifibrotics, or will you give him high-dose steroids over and above the usual ones? So please, we are beginning with the polling. So please start the polling. Yeah, please answer either A, B, C, or D. We want maximum number of people to answer. Yes. Last, we'll give you 10 more seconds. Okay. Okay, last 5 seconds. Okay, I guess we'll stop the polling. Please stop. Okay. So we can share the results. Yeah. So I'm very, very happy after seeing these results. A massive majority of 71% has said that we will just give supportive care, physiotherapy, and breathing exercises. And very few people have said that you can give tocilizumab, and some have said that give steroids. So majority wins in this case. And so the answer is we have to just give supportive care. We have to give them good physiotherapy, pulmonary rehabilitation, good diet, good nutrition, and good exercise. Okay, so I'll be back to the presentation. So I'll come to it, why other options are, yeah, just a second. Can we have the slides, please?
Just minimize the Zoom.
Okay. Okay, just a second. Yeah, so I would just put few slides on why the other options are not the answer. So tocilizumab, as we all know that it is an anti-interleukin-6 monoclonal antibody. And we have seen like so many reports in newspapers, like there's a shortage of tocilizumab and we need to have it more. But unfortunately, tocilizumab is one molecule which is not of that much utility that we have found out. It does not grant you a survival benefit, and it has to be used strictly in patients who are rapidly deteriorating. Say we have a patient who is admitted in the ICU, and within 24 to 48 hours, he has rapidly, his oxygen needs have increased. That even first we started on nasal prongs, then he is requiring say face mask, then he is requiring HFNC or NIV. Then this patient has rapidly deteriorated, then and he is in the first 3 days of admission. That is what is the most important criteria. It is that you have to give it in the early phase of the disease as soon as the patient is admitted and he is deteriorating. Don't give tocilizumab if only his interleukin-6 levels are rising, but the patient is stable. And as we have seen that, after exhausting all the options that patients are given for 8 to 10 days, we are giving remdesivir, we are giving steroids. And then if the patient is still worsening, the relatives are sent skirting here and there in search of tocilizumab. So that is not the case. So it is not indicated in the later part of the treatment or the management. And it is, if it is given only in the first 3 days and especially in the first 24 hours if the patient is rapidly deteriorating. Otherwise, it is not given. It can prove more harmful rather than useful because it is a potent immunosuppressant, and it can diminish your defenses to such a low level that the patient may fall prey to sepsis, and he may subsequently, it may lead to death. So be very, very careful while giving tocilizumab. And otherwise, even if you give tocilizumab, it is given in a single dose of maximum 800 mg per 800 mg. Don't give a second dose. That is not given in any of the, recommended in any of the guidelines. Next, it's not going next. Wait. Just a second. Okay. I'm very sorry for the disturbance. Okay, so tocilizumab, we have gone, and steroids, our previous speaker has nicely mentioned that it is like here, it is one of our favorite drugs and we like to give it left, right and center. But please give steroids only in selective patients. Give it to only those patients who are hypoxemic, that is the oxygen concentration is saturation of patient saturation is less than 93%. Then on room air, then only you should consider giving steroids. And whenever you're giving steroids, give them for a limited period of time, not endlessly, like 1 month, 1.5, 2 months. You have to give it maximum for a period of 10 days, and you can give it in Dexa form of 4 mg twice a day, or give them methylprednisolone or hydrocortisone, whichever is available. Never start a patient on steroid. Never start steroids in a home quarantine patient. That is the main gist which we want to suggest. Secondly, steroids are, we all know that it is a wonder drug, and it is what we can say, it is the only drug which has been proven to be of significant benefit in reducing mortality. So no doubt it is a very good medicine, but give it in the proper dose and the proper duration. And one more thing is, we know that there are a lot of cases of mucor coming up in India. So one of the reasons postulated is the high dose of steroids which the patients are receiving. So please be careful. It can be a double-edged sword and lead to more harm if not given in a proper way. So next, one more option which I had, just a second. So as you know, I had just one more slide. I had put that whether you should give the patient antifibrotics. So antifibrotics have also been discussed. I will be discussing it again in the second case which I am presenting. But one thing is for sure, that a patient who is requiring only minimal amounts of oxygen, and he is not, in a requiring long stay in the ICU is not there, or he is not requiring NIV, HFNC. So antifibrotics are of doubtful value. You can definitely start maybe after doing a PFT, after his 28 days of COVID infection are over. Don't be in a haste and, start him on antifibrotics. I'll present to you my data also subsequently. So now we'll go to the second case. So second case is of a 64-year-old male. He was again admitted in a COVID hospital, and for a long time he was there in the hospital, for around 2 weeks in the ICU and 1 week in the ward. He was mildly tachypneic when they discharged him, and he was requiring mild oxygen. So he was discharged on home oxygen. But suddenly after he goes home, after 1 day, he becomes breathless and his saturation drops. And so the relatives come to me saying like what they should do. He's COVID negative and what we should do. So I'll just show you the question. So in this case, what will you do? Will you admit the patient, give him high dose steroids, or will you admit and start him on BiPAP? Will you do a HRCT chest, or will you diagnose as post-COVID fibrosis and tell him that it is a long-standing one and give him pirfenidone? So I'll begin the poll now. Please, we can start the poll. Yeah, so the time begins now. Please answer in large numbers. We are waiting. Okay, we want at least 400 responses. Yeah, please. Okay, 5 more seconds we are giving. Okay, I think we can stop. Okay, can we have the results? Okay. Okay, so majority have said that you can start on BiPAP. Some have said they can do it. Equal number have said they can do HRCT chest, and some have said give pirfenidone, and some have said give him steroids. Okay, so I'm fairly satisfied with the answers. So in this case, I would ideally like to admit the patient. If he is too much tachypneic, start him on BiPAP. And then also do the most important thing I have not mentioned, deliberately I have not mentioned the complete answer. I would like to do a HRCT chest along with a CT pulmonary angiography. So as we all know that COVID is a very prothrombotic state, and there is a high chance of microthrombosis, microembolism, and even when the patient has received good amount of anticoagulants when he is admitted and we are giving them oral also, still they have a high propensity to develop thrombus and subsequent embolism. So this patient was definitely a high risk for embolism, and so ideally I would do a HRCT chest, admit the patient, do a CT pulmonary angiography. BiPAP is also not a completely a wrong answer, but that's not what I want. Diagnose as fibrosis and give pirfenidone. Okay, pirfenidone is one of the, we can definitely give in this patient because he was long standing in the ICU with NIV, etc. But this is not what I want right now. High dose steroids completely out of question, because as I mentioned earlier, he has already completed 3 weeks of treatment management in the hospital, and therefore steroids don't have any role in this case now. In fact, we know that many cases of infection, secondary bacterial infection, tuberculosis infection crop up in the later part of what we say post-COVID time, and that is why giving steroids would be very, very detrimental to the patient. So in this patient, unfortunately, he had exhausted all his finances and he was not ready for admission. So we did his HRCT and CT pulmonary angio on an OPD basis. How do we start again? Just a second. Escape here. There's some problem with the press. Yeah. So I will show you the first CT scan. So this was we had done in November 2020 when he was admitted. You can see a lot of fibrosis and then ground glass opacities in the lower lobes. Then we can see a small peripheral wedge-shaped consolidation. This was probably the pulmonary infarct. We confirmed that it was pulmonary embolism on CT pulmonary angiography. And since he was not willing for admission, we started him on oral anticoagulants. Xarelto we had started. So this patient, we repeated, we gave him anticoagulation for about 6 months. So we repeated his CT scan. You can see the CT scan in April. So you can see that the majority of the changes have reversed and the pulmonary infarct has also gone. Then in the second picture also, we can see that majority of the ground glass opacities, etc., have gone, and there are few still, fibrotic elements and few areas of honeycombing which are still seen. So maybe that will also improve. I will show you what has happened with the patient. So we did a lung function test after the patient got discharged, and say about 4 weeks from the date of infection. His FVC was very low to begin with. He was severe restriction. So 32% falls in severe restriction category. More than 80% is normal. But as you can see that gradually after 3 months, his FVC increased to 64% and presently it is 82%. So in spite of the few CT scan changes being persistent and so much of hospital admission and then so much of embolism, still the patient was able to recover completely. His lung capacity has come back to normal, about 82%. And initially, the patient could walk only a few steps, and that too with desaturation. But now, presently, he can walk he can walk up to 15 to 20 minutes without any breathlessness. There is a bit of desaturation, but no symptoms at all. So you can see the dramatic improvement which he has got. And like one of the options, many had said that give pirfenidone, so they are not wrong. We had also started pirfenidone. Pirfenidone was already mentioned in the discharge summary when the patient had got discharged, but the pirfenidone was given in a low dose. I will come to the exact dose soon. And then we gave pirfenidone for some amount of time, but the patient had severe GI side effects and he couldn't tolerate it, so we had to stop it. Then we thought that we will give him a trial of nintedanib, which is a newer antifibrotic agent. So we started him on nintedanib, but again the patient developed a lot of loose motions, a very big side effect, dose limiting side effect, and it is most of the times refractory to your pre and probiotics. So unfortunately we had to stop nintedanib, pirfenidone both. So you can see that the improvement which has occurred, so it is mainly because of his rigorous physiotherapy, a good pulmonary rehab team, and a good diet, exercise, and obviously mental well-being. So all these things contribute mainly to the recovery of the patient, which is proven by these facts. I will show you some data also. So we analyzed about 80 patients, that much we could manage right now. So 80 patients of post-COVID illness, and majority of them were having a long hospital stay with and they had been given BiPAP, HFNC, etc. And there were all kinds of patients from young, middle age to old. And what we found out was something very interesting. So as you can see, the average FVC, or the forced vital capacity, was 70%. So which is a very, very good number. Like I told you before, like the normal FVC in a PFT is more than 80%. 60 to 80 is mild restriction, less than 60 is 40 to 60 is moderate restriction. So majority of the patients fall in the category of mild restriction. I'll give you in a graph, in a pie diagram also. So here we can see, so this red part, which you can see very clearly, this red part is showing 1/3 of the patients did not have any restriction in spite of such a COVID illness. 1/3 of the patients had mild restriction, FVC between 60 to 80, and around 1/3 patients had moderate to severe restriction. So mainly what we predict is that pirfenidone or antifibrotic should be used in this category of patients who are having moderate to severe restriction. Maybe that will work better, and I don't think there is any use to give pirfenidone in this remaining 60% of patients. So maybe the bottom line is that maybe we should always do a PFT before starting pirfenidone. If you want, you can give the patient when he is admitted, but then if the decision to continue pirfenidone or not will depend on the further PFTs which we can do. This is also a FVC graph which we have plotted from our own patients. So we can see the blue is in the blue shows the FVC in the initial at baseline, and we can see at the end of 3 months and the 6 months the FVC value has kept on increasing. So just most important point I have forgotten to mention is that this 80 patients which we have analyzed, they haven't received pirfenidone or nintedanib. Both we have not given due to many restrictions, like as I told you, majority of the patients had mild restriction or no restriction, so we avoided giving in these patients, but we wanted to give in the patients who had moderate to severe restriction. But unfortunately, even they could not tolerate, majority of the patients didn't tolerate pirfenidone or nintedanib, and then some, because of the high treatment cost, they were not willing to continue beyond few weeks, I can say. So these two things were the major dose limiting, were major limitations for us, that we were not able to give pirfenidone. But in spite of that, so I can say around 80%, around the 80 patients which we have studied, none of them received pirfenidone for a long time. So still they could manage the FVC, tremendous improvement in FVC over time. This also graph shows the same thing. The initial levels of FVC are quite low, between 30 to 50%, and you can see how the increase has occurred over a period of 6 months. Okay, so so most important thing is, like, if you want to start pirfenidone, there is no harm, but you have to keep certain things in mind, that the dose which we have commonly seen is 200 mg thrice a day, but that is not the dose. Pirfenidone, the ideal dose is 1800 to 2400 mg per day. It's a very, very high dose. And so if you're giving a 200 mg tablet, the dose is 9 tablets per day. So that becomes a very huge tablet burden for the patient. And that is one of the major reasons for discontinuation. But nowadays we are getting one different formulation in which the dose of pirfenidone, one tablet is containing 801 mg in one tablet. So this dose can be, you can give at one tablet, you can begin with one tablet, and after a week, every week you should increase to by one tablet. So first week one tablet, second week 2, and third week final dose of 2400 mg, sorry. So you can just monitor the side effects. GI side effects are most prominent. Some patients develop photosensitivity and rash also. Very few cases are having liver dysfunction. So we are giving pirfenidone for idiopathic pulmonary fibrosis since the year 2013. There are very, very few cases of liver dysfunction. Nevertheless, you have to monitor liver function tests when you are giving pirfenidone. So the other new anti-fibrotic agent which we have recently, it has been launched in India only last year, around 7 to 8 months back, is nintedanib. So this is also, the final dose is 150 mg twice a day, but you can begin with 100 mg twice a day, then gradually you can increase to 150 mg twice a day. As I told you before, even our patient could not tolerate it because of the refractory loose motions. So keep a watch for the same. And one more thing, very, very important thing is, antifibrotics cannot be combined when a patient is already receiving the oral anticoagulants. So nowadays we are seeing that we are giving anticoagulation even after the patient is discharged, maybe for 7 days, 14 days or 21 days, whatever. So in these patients, the patients who are on rivaroxaban, they are on dabigatran, they cannot be given pirfenidone along simultaneously, because there is a increased risk of bleeding in these patients, and it is better to avoid them together. So there was a one more conclusion which I would like to say from my study is that, okay, you can give antifibrotics, but give them after doing a proper PFT, and then you select the patients who you think would benefit from pirfenidone, because it has got its own share of side effects. And then if you're giving it, give it at a proper dose, and don't expect any miracle like this from this drug, because we showed you the data. It showed that even after not giving pirfenidone, the lung capacity has improved. So it underlines the fact that good pulmonary rehabilitation plays the most important role. All these medicines, antifibrotics, you can try, but they are a slow acting agent. So even in patients of interstitial lung disease, when we are giving them, they don't give a dramatic response as we expect them. So don't expect too much from them. But then yes, if patient is able to tolerate, you can no doubt consider starting in selected patients. So there was an interesting article which had come in Lung India, and we can see a lot of articles on post-COVID fibrosis in newspapers, and due to which the patients, patients nowadays come with that diagnosis also, that doctor, I've got COVID fibrosis, and my doctor has said that you have got COVID fibrosis, and then your lung functions have gone for a toss. So all this thing, there was a big study, and they anticipated that a big tsunami of post-COVID fibrosis will come, and the pulmonologist will be minting money. But fortunately or unfortunately, this is not true. As I've shown you from the data, the lung has got an excellent repair mechanism, and that is one of the best things which we are having. So even though medicines don't work, natural immune system, natural mechanism, God-gifted ones, they are the ones which are going to help you finally to get out of this COVID fibrosis. So we don't term COVID fibrosis before 3 months of maybe 3 months post-COVID. We always do a PFT at baseline and after 3 months. And after 3 months also, if the patient is having breathlessness and if the patient is having a lot of severe restriction, then we can label, that the patient is having post-COVID fibrosis. Initially, it is just post-COVID inflammatory reactions, and you should not ideally label them as fibrosis. So this theory that the tsunami will follow has been completely shattered. And one last slide, I would like to say that please, we have seen such slides also. It is suggesting that patients have been given nintedanib as well as Perfinex as well as Visalone. So all these three things have been combined, that complete masala has been given to the patient, and the patient will feel that, that I'm going to improve completely. So that is not the case. Never, 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 please combine Pirfenidone and nintedanib. Two antifibrotics cannot be combined, and don't ever give steroids in the post-rehabilitation phase. So this type of prescription deserve to be crumpled, and we don't want, I don't know, the aim maybe of this treatment is to make the lung soft like cheese, but no, we need good aeration in the lung, so cheese won't help in this case. So thank you very much. I am sure you found something worthwhile in this session, and any questions I am free to answer in the panel discussion. So together we can, and together we will definitely overcome this menace of COVID soon. Thank you.
Thank you so much, Dr. Poonam, for clearing many concepts and providing insights in management. Next, I would like to call upon the extremely renowned and respected radiologist from Western India, Dr. Bhavin Jankaria. He runs his own comprehensive center named Picture This by Jankaria Imaging, which has been a pioneer in the field of diagnostic radiology in not only India but also entire Asia. Today, he will clear the mist surrounding the CT scan in COVID and provide us with invaluable insights which will guide us in day-to-day practice. Please welcome Dr. Bhavin Jankaria. Over to you, sir.
Thank you for that kind introduction, and I'd like to thank Dr. Subramanian, Natarajan, and Poonam, and everyone for inviting me to give this talk. So I'll spend the next about 20-25 odd minutes talking about imaging and COVID-19, and then, as we had agreed, I'll take questions right away because I won't be able to wait for the discussion. So today's talk is really focused on the chest, and then a little bit about the heart and a little bit about some other complications that we're seeing these days. Now, I'll spend some time on what we see on CTs, and then we will talk about indications and other issues. The signs, classification systems, severity scores, you already heard from Poonam as well, but I'll spend some time on angiopathy and vasculopathy and this so-called fibrosis and short and medium-term follow-up. These signs that we have are standard. We need to talk about the CORAD's confidence system and then about severity scores. So the three main signs are ground glass, consolidation, and reticular opacities. Ground glass is increased opacity that does not obscure the underlying vessels. It can be subpleural, can be central, but in most instances is perivascular. So this is a new group of signs that we're seeing where we see perivascular ground glass. Now, if this ground glass is associated with septal thickening, we get the crazy paving pattern, which we knew earlier occurred with alveolar proteinosis, but now we're seeing it with COVID-19 patients too. We can then see consolidation. Most of the consolidation we see follows an organizing pneumonia pattern, so can be subpleural or can be peribronchovascular here. And sometimes we just see them as subpleural bands like you see here. We can see combinations. So here we have consolidation with surrounding ground glass as a halo. And here we have ground glass in the center with surrounding consolidation, which is called the atoll sign. We also see these thin and thick bands with apparently normal lung here. They are paralleling the pleural surface. We now know that this so-called normal lung is hypoperfused and the bands are actually due to edematous lung. But that's what we've learned from the whole concept of vasculopathy. When the disease becomes severe, the patients get cytokine storms, get admitted. We see diffuse lung injury presenting as an ARDS pattern, but there is this characteristic sparing of the anterior segments of the upper lobes that we see here, and the rest of the lungs show a combination of consolidation, ground glass. You can see bilateral pleural effusion, sometimes pericardial effusion, and we know that this patient basically has diffuse alveolar damage and acute lung injury. Histologically, it's a combination of AFOP, fibrosis, OP, and DAD, and now we know that there is an endothelitis component as well. When you see the radiology reports that are given out, one of the things that all of them will mention is the CORAD system, which is a commonly used confidence system for diagnosis. And what it says is that if the radiologist says that it's CORADS 5, then it means that the radiologist is 100% sure that this is COVID. With CORADS 4, the level of confidence is upwards of 90%, which is good enough. When I say CORADS 1 and 2, it means there is no COVID. And CORADS 3 means, I'm not very sure, perhaps there is, etc. So CORADS 1 is normal lung. CORADS 2 is when you suspect COVID clinically, but it turns out to be tuberculosis, as we see here. CORADS 3 is truly, we're seeing some ground glass. I'm not sure what it is. It could be something else. And so we need to be more sure about everything. And CORADS 4 and 5 are where we see typical patterns where we are confident this is COVID. And so that score gets put down. How good is CT chest? It's getting better and better as we get better and better as radiologists. And currently, this is a live 3-monthly review that the Cochrane people do. And it's reached 90% sensitivity and 80% specificity. And in many instances, people get much better depending upon their experience and expertise levels. Then we come to this one bugbear of the severity score. So let's see how this is done. So 95 to 98% of people or radiologists in the country use this semi-quantitative or semi-autom. It's not even semi-automated. It's actually an entirely visual method of scoring out of 25. So the way it is done is that we take the 5 lobes of the lung and we visually try and see what is the extent of lung involvement. So here, for example, the right upper lobe that we see here on the axial, coronal and sagittal is not involved. So the score is 0. The right middle lobe shows very subtle involvement here and here. So that's less than 5%. So the score is 1. The right lower lobe shows some involvement, which is 5 to 25%. So the score is 2, and so on and so forth. And then you tabulate the entire thing. And this patient has a score of 8 by 25. And we know that if the score is greater than 15, typically it predicts a worse outcome. But we must realize this is not a severity score. It's an extent score. All that the score tells us is the extent of involvement of the lungs. Severity is a clinical concept, and you can have a person with slightly more extent of, let's say, 15 or 18, but who's clinically fine, and vice versa as well. Also remember, because this is visually done, there is a huge inter-observer variability, and there is some intra-observer as well. So the same person on the same scan on 2 different days could give you 2 different scores, one day 14, one day 16, and that does happen as well. So we should know the limitations, but please understand that because all the radiologists and physicians and virtually all doctors in the entire country use this, right? It's one of those rare instances where everybody is pretty much using the same scoring system. We need to continue with that because it allows us to speak the same language. The next issue is of angiopathy and vasculopathy. And while the general belief is that the findings that we see are due to viral pneumonia or immune changes, the vast majority are because of the endothelitis that occurs and the consequent changes. And what are the CT signs of angiopathy? We see these large vessels either proximally or in the center. We see the vascular tree in bud, where we see this vessel which has these micro thrombi, and therefore you see them budding out. It's like the tree in bud of TB, but this happens with vessels. We see the target sign. There's a vessel in the center, there's perivascular edema, there is this normal looking lung, which is actually hypoperfused, and then the hyperperfused area of ground glass. We may see actual thrombi, but most of the times we don't. In this patient, we also see a target sign. And in these patients, if we do a dual energy CT pulmonary angiogram, we can see large perfusion defects. So you can see in the mid zone here, there is virtually no perfusion. There's nothing, even though there is no thromboembolism, but in the lower lobes, there is hyperemia. So this is very, very characteristic of COVID-19. And that's the list of the various signs if you would like to see them. Then we come to short and medium term follow-up and so-called fibrosis. And typically, in the vast majority of patients, we have lesions like these and they regress within about a week or a month. But there is a percentage of patients where the regression takes longer. We also see now these patients, and nobody really knows what to do, right? So normal lungs, 2 months post-COVID, and severe perfusion defects that we're seeing on CTPA. And in fact, a recent study that came out of France said that 2/3 of their patients who on follow-up, they did a DECT, they found perfusion abnormalities. And there's been this recent study that came out of Oxford where they've used a fancy technique called hyperpolarized xenon MR, which is only used for research. And they found that even up to 172 days post-discharge, even with normal looking lungs, there was abnormal gas exchange and abnormal alveolar diffusion, which correlates with the reduced DLCO that you often see in patients, even if their lungs look normal. So we have had now 9 and 11-month follow-up patients. This is a patient 9 months who follow-up who has been slowly improving. Even the March scan is slightly better than December, but this patient is taking a little longer for his lungs to improve, though clinically the patient is much better. Then we had this learning where we saw a patient who had significant traction bronchiectasis. We know that traction bronchiectasis implies fibrosis in non-COVID patients. But now we know that in COVID patients, all these learnings have been appended and the traction bronchiectasis is gone 9 months later, right? So it tells us that we can't use the term post-COVID fibrosis. And for the last about 9 months, all that we say in our reports is the presence of COVID-19 lung sequelae. Because branding somebody as fibrosis doesn't really help anybody. And we don't know enough. We don't know what's happening to these patients. We know from the follow-up of the first SARS pandemic that after 7 years, the vast majority will improve, but we don't have the answers. And in fact, I've just put up a 5-minute video on this topic at ctchestreview.com. You can go and look at it. But here is a patient with 11 months follow-up, right? And we see significant disease here. Here we've started seeing traction bronchiectasis. Again, we might say that this patient has fibrosis, but here is the patient with significant improvement and just some residual reticular opacity. So the vast majority will improve. Some will not. Right now, we don't even know who will improve and who will not. And we don't even know the implications of residual lesions in the lungs if they are clinically improving. And we don't know the implications of normal lungs with reduced DLCO in patients who have perfusion defects, because we don't even know what to do with these patients, right? Except, of course, in India, where you can give antifibrotics like water, give anticoagulants like water. You can do pretty much whatever you want, because that's just the way we are. So, but most of the other countries, you can't even give any of these medications. And so that's where you can do the trials to figure out what works and doesn't work. So then we come to this indications of CT scan. And if you look at the ministry guidelines, which came out a little too late, they just came out about 3 weeks ago when they should have come out in the middle of the second wave in March and April. And if you follow these guidelines, then more than 90% of CT scans done for COVID-19 would be unindicated. And I'm absolutely fine with these guidelines, except for three things. One, radiation exposure. It's been 129 years after the invention of the X-ray machine, after the discovery of X-rays, and 128 years after the invention of the X-ray machine. Not one study that shows that radiation due to any form of medical imaging produces cancer. So this statement is incorrect and wrong. And again, I have a video and a post at CT Chest Review that you can go through if you want. Not done for the purpose of diagnosis. This is fine, except when you're faced with the situation which in Mumbai we had for 1 week in April, where the labs were not giving reports for 5 days because they were backed up. That is the one time when you're not going to get your reports within 24 hours that a CT chest works as a substitute. And I think that you cannot discount. And of course, the cop-out that everybody has, which even the guidelines have, is in the end, of course, the treating physician can decide whatever is the right indication, which means in the end, whatever you've written down becomes invalid because you're leaving it to the physician to decide based on clinical assessment what is right. And then you can't discount that. If the physician truly believes a CT is required for diagnosis or management or for doing a 3-6-9-12 schedule, then so be it. So as part of our Society of Chest Imaging and Intervention, we actually came out with guidelines for where CT chest is not indicated. It's not indicated in routine evaluation. It's not indicated for pre-admission or pre-surgical evaluation. It's become so stupid even now that the clerk at the admission counter asks the patient कि तुम्हारे रिपोर्ट में कोरैड्स 0 या 1 or 2 लिखा है ना तो ही हम लोग एडमिट करेंगे. And I'm sorry for using Hindi for those who don't understand Hindi, but this is ridiculous. If I give a normal report saying the CT chest is normal, why does the clerk want CORADS 1 or 2 written on the report? This is just completely insane, but it's still going on in every damn hospital in this city, right? I don't know about the rest of the country. And obviously patients, relatives, there's so much FOMO, the fear of missing out on WhatsApp groups now, where the patient's relatives and friends tell the patients, hey, why are you not getting a CT done? Everybody gets it done. You must get it done. And then, of course, we don't have the time to handle multiple queries. So then the patient says, I'd want a CT. You try once to say it's not required. Second time you say, go to hell, yeah. Go and get it done if you want to get it done. Same thing here, management. These are the things you should not really use it. We know that there are hospitals, especially during the middle of the pandemic, who had this protocol 0, 3, 6, 9, 12, 15, 18, 21. Every 3 days do a CT. I mean, what rubbish. But, that's just something we need to be a little more aware of. And again, these guidelines should have come out from the ministry in March, April, not in the middle of June. And then obviously for routine follow-up, it's not indicated, and definitely not when patients and relatives want this. And then obviously the rest of the times, it's best left to the treating physician to decide. So let's move to the heart. We've been seeing quite a bit of COVID in the heart. This was the first patient we saw last year, a 53-year-old man with failure, inferior wall infarction, that's on the short axis, some thrombi here. And when we looked at the static images, we saw some wedge-shaped areas that were very suspicious for COVID. The lung window images, we just had a quick CT done that showed COVID. Then they did the RT-PCR. And we still don't know whether the patient had an infarct and then was COVID, or whether this was COVID-related infarction. That's a mystery. But what we are seeing is COVID viral myocarditis. And most of the times we see them 2, 4, 6 months later when they present with reduced ejection fraction. But very often we see them like this, a 21-year-old with an acute coronary syndrome, acute chest pain, RT-PCR positive. This is on the 5th day, raised troponin levels. And you can see this wall motion abnormality in the anterior wall and anteroseptal segment, which on our multiparametric imaging shows edema on the stir, raised T2, extensive enhancement, which will eventually become fibrosis. So that's another manifestation. And while we don't have numbers, we do see about 2 patients a week now with either subacute or chronic COVID-related or presumed COVID-related myocarditis. Then a couple of interesting situations because of the large number of CT scans being done. I mean, there have been centers in Kolhapur and Sangli and other parts of the country that were doing 200 a day. And I can't even imagine how you can do those. But that has led to the pickup of all kinds of lesions. One of them was this patient who had this lobulated lesion picked up in the right upper lobe, which I then biopsied, and it turned out to be adenocarcinoma. We picked up lymphomas, thymomas, other lung cancers, tuberculosis, all kinds of things. So, I mean, that's one of those things that happens when you almost land up using CT as a screening tool. And then lastly, a couple of complications. This is a patient who had COVID in October, but had that entire cocktail given and landed up with miliary tuberculosis 3 weeks ago. Now, it could be coincidental, but in the last month, we've seen 2 additional patients who've had miliary TB. You can see these COVID-19 changes here, and now you can see these 2 and 3 millimeter size nodules that are randomly distributed. So that's probably because of reduced immune status, because of all the drugs, and perhaps the immune modulation that COVID does itself, that we're seeing this. And lastly, the 60-year-old lady who presented with acute neck pain in early May, the MRI shows this posterior epidural soft tissue here. She had COVID in February. And the differential was everything from lymphoma to tuberculosis, etc. And so everyone was freaking out. And we said, okay, at least let's get a PET CT done. And the PET CT didn't show any uptake. And then we figured out that she had been put on long-term anticoagulation that had not been stopped. I have no idea why, but she was on anticoagulation. So then the obvious thing was that this was a posterior epidural hematoma, because if it was infection or tumor, it would have lit up on the PET. And so we did tell them to trust us, not to do anything. They agreed. And then 6 weeks later, you can see that the entire hematoma has gone. So complications of anticoagulation given in patients with COVID. And I remember 6 months ago, we saw an acute psoas hematoma because of that. We haven't seen too many others, but I assume they're out there bleeding in some parts of their body because of this. So that was the idea today, to talk about CT chest, predominantly to present what we see in these CT scans, to talk about the CORAD score, how we do severity scoring, which is actually extent scoring, and then to talk a little bit about indications, and then spend about 3 or 4 minutes on the heart, and then a couple of minutes on some of these interesting situations that are now cropping up, especially now that we're about 1 year and 3 months into COVID as far as the first wave is concerned. And we're seeing all kinds of things happening. So that's pretty much it. Thank you so much for your attention. And again, thank you for inviting me to give this talk. So are we doing any questions or?
So thank you, sir, for an extremely comprehensive talk, and you agreed to become a part of our CME. That is indeed a very great thing for us. So thank you once again. We have a couple of questions for you. So first thing is, like, do you recommend repeating a CT scan in a post-COVID patient who has got thromboembolism? And for after how many days?
If the patient is doing well, then no. If the patient is not doing well, then depends on the clinical situation. There are no protocols.
Okay. And one more question is from Dr. VSK's name is not seen. He is asked that, is there an AI-based software for early diagnosis of COVID on chest X-ray?
Yes, there are not one, there are about 400 of them all across the world and maybe more. But they are all useless. They work in the environment in which they have been shown to work, but they cannot be deployed for use in clinical in the clinical environment. There are lots of shortfalls. There are issues. There are medical legal problems. There is lack of validation over a period of time. I mean, I can't get into those things, but yes, the softwares exist. They're easy to develop, but they are not to be used.
Okay. Okay. So one more question from Dr. VSK again. He has asked you whether you have seen a lot of disseminated tuberculosis cases post-COVID.
Not too many. Like I saw the miliary TB, which was lung, liver, spleen, and they were to do an MRI brain, but I don't have a follow-up. And there have been some couple of lymph nodal TBs, but I have not seen a lot of disseminated TB.
Okay. Yeah, and so one question from Dr. Hemant Baheti. So he has asked, just a second. So Dr. Hemant Baheti has asked that how long can active lesions be seen in post-COVID? On
I
CT scan.
understand the question. Activity, how do you judge activity? Activity is on the, I mean, there's nothing like active lesions. When you see them for the first time, that's so-called active disease because your RT-PCR is also positive. After that, these lesions are a combination of edema and inflammation and stuff like that, and they go away. Most of them go away. So, and even the ones that don't go away, we don't know what that actually is. I mean, it's not fibrosis, that is for sure, because it is all regressing over a period of time, and fibrosis doesn't regress. That's the first and most important thing. Even with antifibrotics, fibrosis doesn't regress. All you do is reduce the progression and reduce the rate of reduction in the pulmonary function testing, in the FVC. That's the role of the antifibrotic. You can never reverse the fibrosis.
Okay. So one question from Dr. Jawahar. He has asked that whether CT scoring can be used when extent is the same, but ground glass opacities have been changed to consolidation.
So, first of all, CT scoring is to be done only the first time, once, never again. There is no rationale for doing CT scoring a second time or a third time or on follow-up, etc. It's to be done once, because that just tells you what the next step is, and then you just talk about progression, regression, etc. The score is irrelevant. So then when we're saying ground glass is becoming consolidation, it means we're talking about a follow-up scan where there is no role for CT scoring. Having said that, what Jawahar raises is an important issue of, the fact that consolidation is worse than ground glass. That is not captured in the CT severity score. There are other morphologic scores that are around, but then they all become individually used. So the All India Institute uses its own score. Breach Candy Hospital uses its own score, which is not really correct, because then you lose the ability to talk across institutions and among physicians, right? So you have to stick to whatever may be the shortcomings of the score. The benefit is that everyone in this country after a long time is speaking the same language when it comes to scoring. That is something that COVID was able to do that otherwise is so impossible to achieve in most other instances.
Okay. So one question from Dr. Mandar Kubal. He has asked that whether have you seen any COVID-like changes on CT scan post-vaccination?
So we've never been able to say for sure, but we've had patients who post-vaccination have developed COVID-like symptoms and have come and gotten their scans done. We don't know if they picked up COVID in the vaccination centers because they were overcrowded, whether they had a little COVID pre-vaccination. We don't know. But I must say that 3 cases, actually more, of myocarditis have been reported from the US post-vaccination with the mRNA vaccines. properly documented, absolutely normal before, and then 6 days later, not being RT-PCR positive and developing myocarditis. So that has happened. Lung change is very tough to tell. Yeah. You don't know whether it's pre-existing or they've picked up actual COVID or whatever. But we'll know. I mean, at some point soon, we'll get more information.
Okay. Yes, and one more question is there from Dr. Hamza. She has asked whether how many modalities are available to diagnose thrombosis like pulmonary embolism and GI thrombosis?
So in GI thrombosis, you would do a CT angio or you would do a direct angio. That's how you would pick up thrombosis.
Okay. So Dr. Jayesh Sheth has asked you whether clinical monitoring and timely appropriate intervention is not enough. Can HRCT altogether be omitted in majority of the cases?
Yes.
So I guess sir has given the answer. So thank you, sir. Over to you, Dr. Tina.
We thank you, sir, for this lucid lecture and giving clear-cut guidelines for the rational use of CT scan in COVID. Our next speaker is an internationally acclaimed epidemiologist whose accurate statistical analysis of COVID-19 pandemic in India has been extensively cited, and it has guided many of the lock and unlock strategies of different state and central governments. Professor Shamika Ravi is a non-resident senior fellow at the Brookings Institution, Washington, D.C. She was the former director of research at Brookings, India. She is a visiting professor of economics at the Indian School of Business. She was also a member of the Economic Advisory Council to the Prime Minister of India. She publishes extensively in peer-reviewed journals and writes regular opinion pieces in major newspapers. Her research work has not only been featured in the BBC, but also by most national and regional newspapers and magazines in India. She will be decoding the COVID-19 waves, which will reveal unfold facts and figures. Please welcome Dr. Shamika Ravi. Over to you, ma'am.
Thank you. And thank you to the IMA and the Lung Center and Dr. Natarajan for this wonderful opportunity to address you, to be here. Well, first of all, I'm not an epidemiologist, I'm an economist, but I am an empiricist, meaning I'm someone who studies data and tries to apply it to the theory or our knowledge of development. So basically, it was in the aftermath of the pandemic that the sort of the lack of public knowledge on what was happening and trying to bring the the public discourse, but also I think dissemination of information, at least statistically, to the wider public was more of a professional service. That is what economists or researchers who work in research institutions, which are essentially non-profit academic institutions. It's really a professional obligation and a service as per which we began to do this. And subsequently, of course, I think there was great hunger. And a lot of the studies we did, the analysis became quite popular. Many people improved upon it. But I must say, being here amongst you, you're all real doctors. I'm really a PhD and in economics. And my talk will be a bit of a variation from what you've been hearing since the morning. It'll be a departure from what you've been doing, in the sense I'm here to give you an overview of how COVID-19 really looks from the perspective of India's real economy, meaning the livelihood of the country, the future growth, to what extent it depends on the current situation, and what are the levers, what's the way forward. So I'll try and address that. So hopefully you can all see my slide. Can someone confirm, please? Okay, I'm just going to assume everyone can. Let's start with the current situation. This is as of 2 days back. We know that there are many people in this country who have recovered, and therefore, particularly over the last several months, are also carriers of antibodies. And we're trying to feed this information also into the vaccination drive, because rather than aiming at averages across districts, we are trying to get the vaccination drive to become a little more scientific in terms of targeting. And move away from the simple mantra of equity for equity's sake towards perhaps a more efficient allocation. So there are huge variations across district. But overall, if you look at what the pandemic in India has been like, we've all been through it. I currently have a family member who's still positive. So it's been deeply personal for all of us. But we do know that while the first wave was relatively muted, if you compare the way it went for the OECD or the richer nations of the Northern Hemisphere, if you look at the way the first wave was managed in India with a preemptive lockdown, though economically very costly, but it did manage to keep numbers pretty low. However, the second wave really is what is the classic case of why we need lockdowns and you need containment strategies, because this is what you ideally want to avoid. And the second wave eventually turned out to be a worse nightmare, specifically for some cities. And we'll talk about the disaggregation. But things are much better compared to how they were a month back or 2 months back. We are reporting now under 50,000 daily cases. These are moving averages, so these are more long-term. These are not day-to-day fluctuations, so they're relatively smooth and consistent. But this is the variation between the first and the second wave. This is really, it hit us very hard, and it's only now that the genome, the sequencing data is able to tell us that it was a combination of many factors, including the variant of the virus itself. And the result, of course, was that we were clocking about 4 lakh cases daily. The health structure, the infrastructure was under acute distress. If you look at the daily death numbers, the second wave again still isn't, even as of today, continues to be much worse than the daily death numbers we were seeing under the first peak. So, and of course, there are issues with reporting, and data concerns remain, and I'll be happy to answer some questions later on it. But even if we are to take the numbers at the face value, the second wave daily deaths still are much worse than they were under the first wave. Testing, it's remarkable how quickly testing was ramped up given the poor health infrastructure across many, many states, particularly the peripheral regions. And we were testing very little in the first 4 to 5 months. But the ramping up again across states and now across almost every district, there is a certain minimum testing facility available, because of which, of course, the numbers have increased, and we've managed now to have test positivity rate, which is catching the infection to a much greater extent than we were earlier. What you're seeing in terms of improvement in the numbers at the national level, and it's important to remember that when we compare India with a European country or the US, ideally you should be comparing all of India with all of Europe. I mean, it's given the variations you have across states in India, which could ideally be a nation in itself, every state. The variations across states are also telling us that the second wave is now receding fast and receding everywhere. Now, this does not include some of the northeastern states. And as of 2 days back, we knew that in Mizoram, the numbers were still rising and significant. And therefore, it remains a huge cause of concern there. If you look at the death numbers, there's been a lot of debate, public discourse on this. But again, rather than discarding numbers, I think sometimes just looking at the numbers, looking at trends, you learn a great deal. And one is, of course, that the case fatality rate globally and in India, it has fallen with time because there's so much more information and treatment protocols, et cetera, have been developed and et cetera. But there are many states where case fatality rate actually continue to grow. in India. And I think that remains a very big concern and a very big cause of larger public health concern in India. That why is it that we're not able to bring it down? If you see Uttarakhand, Punjab, of course, has the highest case fatality rate in the country. But if you see places like Uttarakhand, Jharkhand, Bihar, Chhattisgarh, many states where the normal trend in the CFR, which you see at the national level and across most other economies, we are actually defying that to some degree. If you look at the smaller states, we are actually defying that to a great degree. Nagaland, Goa, Meghalaya, Himachal, Manipur, they've all consistently seen a growth in the case fatality rate. And I think this needs further scrutiny as to why this is the case. Is it just better reporting of data with time, or because there is greater scrutiny, or is there something fundamentally broken? But this is a cause of concern. The larger current focus, of course, is the vaccination drive. And you're seeing that after an initial slow start, there was a big pickup, but because of the constraints in the supply, the manufacturing constraints, we did slow down considerably. And it's only now, over the last week or so, that you're seeing another pickup, a very significant one in the overall, if you look at the number of people that are getting vaccinated. Of course, the important thing to remember is that there is a growing tension. If you look at the gap between male-female happening at the all India level, and that is a matter of policy concern. If you just look at the doses, ever since our policy has changed regarding spacing of the first and the second dose, you're seeing that while the first dose has really ramped up considerably, you're seeing that that pickup is not matched by the second dose because of the policy. But this is the growth rate or the speed of vaccination in India. You can see that post mid-April, it had slowed down considerably. Again, I believe it's on account of the manufacturing and the supply issues. But it has picked up as of end of May, and as of mid-June, the ramp up is actually quite significant. But India is a very big country, and from a public policy perspective and a health policy perspective, the variations across state remain a huge concern. Because while you see at an all India level, we have 33% people who've received at least one dose. UP is clocking about 20%, Bihar 21%, and you have, of course, Himachal, Uttarakhand, etc., which are clocking more than 50%. So those variations are a big cause of concern still. In terms of fully vaccinated population, this is eligible population, India has crossed about 5.7, but again, you have enormous variation. Delhi has covered 11% population fully vaccinated, while UP is still around 2.9, so cause of concern. If you look at the gender gap, it is not just that the gender gap in vaccination is significant, but it is rising and rising fast across almost all states. And this goes back, of course, to the larger public health concerns about gender and access to health. But in the current situation of COVID, given the infectious nature of it, given the negative externalities, having a big gap between men and women is a cause of concern from the point of view of the infection remaining despite considerable vaccination. You will have many unvaccinated women still susceptible and likely to carry the infection. So this is a matter of policy concern, huge concern. The other is the urban-rural divide is quite significant. I'll show you just two examples of UP and Tamil Nadu. If you look at the state of UP, then Gautam Budh Nagar, which is Noida, has crossed 80% population have received single dose. And you have Raebareli, Badaun, Sitapur, etc., which are less than 10%. This enormous variation is consistent across almost all states of India. This is Tamil Nadu. Now, one of the things to note is that when it comes to UP, a constant explanation is the literacy levels or levels of awareness, etc. But the reason that vaccine hesitancy cannot be just written off as on account of illiteracy or lack of awareness is because a state with a much higher literacy rate and public health infrastructure and awareness, like Tamil Nadu, is also showing similar discrepancy of variations across cities and rural districts. You have Chennai, the Nilgiris, which have attained high levels of vaccination, while you have Tiruvallur, Kudalur, etc., which are still reporting relatively low. Now, I'll get to the real economy because that is my interest. India remains one of the very few countries which has experienced a major decline in economic activity, despite reporting relatively fewer deaths per million. Now, even if those deaths per million numbers are questionable, and we are going to see a rise in that number with time, with greater scrutiny, with more reconciliation, it's unlikely to match the death numbers that many of the OECD countries have reported. And yet the economic decline is severe. And the research suggests that a lot of it is an account of the fact that public health infrastructure is really quite limited. And it's the risk and the uncertainty that lingers in the population, because of which economic activity is likely to remain subdued until we have a minimum number of people vaccinated, or there is an assurance that a minimum number of beds, a minimum infrastructure is available, readily available, testing is readily available, etc. So I think COVID will continue to remain a cause of concern even after vaccination, because eventually it will be the minimum supply of public health infrastructure at the local level, which will determine whether economic activity will pick up in that particular district or not. If you just look at India's experience vis-a-vis many of the other developed countries, if you look at economic mobility as a proxy for economic activity, you'll see that India's decline in activity was similar to most other countries. This is last March, when everyone basically went into lockdown. Different national lockdowns were imposed within a week or 10 days of each other. That huge decline in economic activity, however, countries did begin to come out of it. And while most of Europe and US came out very quickly, India had a very prolonged period of lockdown, and then subsequently prolongated phases of unlockdown. And you see that economic activity was very slow to pick up, but it remained consistent in terms of a slow but a steady increase in economic activity. And of course, because Europe was very quick in unlocking, they had the huge second wave, because of which, again, economic activity declined. And you had a convergence around early spring. But what you do see is that while Europe, on account of higher vaccination and not seeing a subsequent major wave after spring, economic activity has picked up in those countries, while India has seen a huge, huge decline. And only now, as of last 3 weeks, the pickup has again started. So economy has started to chug along, though slowly. What holds at the national level also holds at the state level. Many state economies are showing renewed pickup in economic activity. Now, important thing to note is that, there are government policies, there are lockdowns imposed by governments, but people are really responding to the virus. The economic mobility, or people's mobility across almost all states, began to decline sharply long before those particular states imposed lockdown. So people are really responding to the spread, the infection and the virus. And I think in some sense, policy is behind if you look at people's responses. And yet, because it's a large country and the nature of these externality in this particular problem is so much, that state policy really needs to be proactive in order to prevent bigger decline. We've had projections of the economy which have really touted India to be the fastest growing economy in this particular fiscal year, but also when it was revised upwards, India was supposed to grow at 12.5% this year, but this is all happening before the second wave in India hit. So there will be downward projections, there will be revisions which are yet to come, but I suspect the first quarter of this financial year has really been much, much slower than anticipated, and that will weigh into the projections. But this is something I want to bring to you in terms of, India is not one health market. India has enormous variation across states. And if you look at where the bottom 40%, where do the poor go for their health needs, you'll see that in states like Odisha, Kerala, Jammu Kashmir, Tamil Nadu, Himachal, these are states where public health infrastructure is good, is decent, it works. And therefore people approach government hospitals for care. While in places like UP, Bihar, Jharkhand, Punjab, Telangana, richer states in comparison, so it's not just a UP, Bihar problem. Places where public health infrastructure is decrepit or does not function well, people rely on private healthcare. Now, this variation that we have across states is going to weigh in majorly if we look at the sustainability of publicly financed health insurance scheme like Ayushman Bharat. Because the nature of private health is such that there will be cost escalations, meaning Ayushman Bharat, which is supported on the back of government infrastructure, where cost escalations are not happening, I think Ayushman Bharat can be sustained as a financial instrument. But in states where it's mostly supported by private care, the cost escalations are already happening. And Ayushman Bharat, the viability of financial instrument like that looks increasingly difficult. So I think from a larger public health financing perspective, I think we have to take into account the fact that different states rely on different public or private, and the health system in that state will determine whether Ayushman will be a success or will lead to huge cost escalations, the kind you see in the US. Important to highlight that, in the US, 18% of the GDP is spent on healthcare. And their health outcomes are very similar to, let's say, Singapore, which really spends only 4% of GDP on healthcare. Now, it's not just the magnitude of the two economies, but the takeaway from that is it's not how much you spend, but really the nature of financing, which will determine the viability and eventually economically what is a sustainable model. So I think that's an important point to take away. The second is we are increasingly dependent, if you look at the current Supreme Court audit of Delhi government, the public discourse, and I hate to admit, but that a lot of the policy discourse is also limited to averages. And yet managing this kind of risk under uncertain environment really requires us to go into more nuanced policy making and management practices. It has to do much more with variation. Can we predict the demand peak for oxygen? What is the supply chain? So these are issues which are really in the realm of operations research. This is really optimization under uncertainty and really requires that kind of specialist. And we're not seeing that nature of documentation or discussions happen inside and outside of media and I dare say even government. This is the decline in consumption. So the economy has really undergone a huge shock to consumption. These are the different quintile groups. So from the richest to the poorest, every quintile in the economy has suffered major decline in consumption. Of course, the biggest decline, which is more than 30% to real consumption, has happened in the middle and the poorest quintile. So we do need to take that into account when we are thinking of a fiscal support. The richest have, the share of the richest quintile has actually increased. Everyone's seen a decline, but the share in the declined consumption overall, the share of the richest has increased. So India is also witnessing now a growth in inequality. And that is again a concern. Very quickly, to give you a sense of what is government's view on this, well, if you read the budget, which is really a short-term strategy to getting us out of this hole, the strategy seems to be, and I agree, I actually support the strategy. The issue is always, of course, about implementation. The strategy is one of spending big on infrastructure through short-term borrowing, but also privatization or disinvestment. India has not had serious disinvestment or reforms happen in the government sector over the last 20 years. If you look at privatization or disinvestment, and I think this year's budget has been quite clear on that account. So we do need to now see implementation of this happen. It's already 5 months since the speech was given. So I'll end with that. I'll be very happy to take questions on any specific aspect of either the waves or the economy itself. Thank you.
Many thanks, madam, for having accepted our invitation for talking in our CME. We had a brief outlook of how economy works for a doctor. It's very difficult. Mathematics is something which we really don't understand much, but I think still we could gain certain things. We have a few questions. One is now the COVID cases here in Maharashtra are quite less, very less. Practically, we are not seeing any patients. Clinically, we are not seeing any patients. Very few numbers are coming, especially in Mumbai, Thane, Pune. But there is a huge fear of this Delta plus variant which is coming. And just yesterday, our chief minister announced that those who were in level 1, level 2, that means least restrictions, everything is open in level 1. That was what we were in Thane, Pune, Nagpur and all. And he said, no, level 1, level 2, we are going by level 3. Level 3 means shops till 12 or 1 or maybe 2 o'clock, then no public transport, a lot of restrictions. So how do you, what is your comment on this? How do you want to take this? Is it right, or should we unlock faster? How is it?
Well, Dr. Natarajan, one thing I think we forget during the stressful time is that we are a poor economy. We have just come out of poverty. With a $2,100 per capita per year, we cannot afford very long sustained lockdowns. So that is the reason why in the second wave, despite it being quite severe, we could not afford national lockdown. I think there is an economic reality to that we have to accept, because the price is very heavy. And as you saw, the price is heaviest for the bottom quintiles. So you cannot have very large aggregate lockdowns. What I think is also scientifically more advisable is more localized containment. And I think despite numbers coming down, given our low rate of vaccination overall, and therefore higher susceptibility, I mean, there is a very large population out there which is still susceptible. Because of that, complete unlocking remains too risky. So you are likely to see what you are seeing in Mumbai and Thane, etc., happen across state after state. That till you attain a minimum level of vaccination and you're able to enforce the local COVID protocols, it's unlikely that we will have China-style containment or Singapore-style containment in any city in India.
Correct. So another question is now, there was an article in New York Times, and they said that the official counts, this was on 24th of May. In fact, I put it on my Insta post also. They said we had 3 lakh reported deaths, 26.9 million cases, but a conservative scenario put the deaths as 6 lakhs, and a more likely scenario for them was 1.6 million. And the worst scenario was 4.2 million of deaths and 700 million of population. Now, we had all these predictions even after the first wave. And then they said serosurveillance is very high. We have 50% of population affected, and still the second wave struck us like a lightning, and we were all devastated. So how do you put this? Is it this New York Times article? Is it you feel it has some valid substance, or you feel still there is more to come for COVID? We still are to see a lot of waves. What do you feel?
Well, first of all, I think it's not just the New York Times. It's also The Economist came up with something similar. And we are having this discourse even within India. Media is having a lot of discussion on what is called excess death. Now, a lot of it is sensational. A lot of it is based on very simplistic assumption that makes sense for the richer countries or countries which have very good data systems. You see, when you're very good at recording deaths, then even if you don't know it is COVID or not, so the cause is not well defined, annual fluctuations can give you a sense of what can be attributed to COVID. So what is excess death in a country which records death well? That kind of an analysis makes sense for those countries. In India, our death recording is quite poor. We have, of course, there are huge variations across states, but that's not all. I think it's important for people to realize that in India, death registration still sits only about 80% on average, but you have states like Nagaland, which one year had 90% death registration, and the very next year they had 9% death registration. So that kind of variation that you have in the death numbers And of course, remember that for the vulnerable population, women, children, we have very large number of domiciliary deaths, meaning people die in their homes without documentation, without any institutional support, etc. I think this is the time. I think this is a very rude wake-up call to India's data governance and data systems to really put the house in order. It's high time we started to invest. But a lot of what the projections or the kind of simple forecasts that some of these publications have made, I think they remain sensational. They don't really tell us very much because it's quite back of the envelope. So I sort of leave it there.
Okay, two more questions from Dr. Mandar Kubal. He's saying every wave we rapidly approach the baseline on the graph, but settle around a high plateau, providing a nice platform for the next wave to come. And how do we negotiate this? How do we negotiate the last mile and drop below the plateau?
Well, eventually, currently, what the science seems to suggest is it's really vaccination. We have to go out and vaccinate as many people as we can. Our eligibility is, of course, still 18 plus, but we do know many countries have started vaccinating young kids as of 12 years. India is also having its trials for younger kids. But again, I think given the enormity of the task and given the state capacity and given some of the data that I just showed you, there are many districts, Rai Bareilly, Kannauj, etc., which have crossed 7%, 8% vaccination, despite adequate vaccine being available at the centers. So vaccine hesitancy, the fear of a lot of this, and I think the biggest source of fear is also lack of information. And we must be honest to ourselves that we know so little. I mean, of course, we know a lot compared to 1 year back about the virus and broader trends, but there is a lot about this virus which remains so dynamic that in a real-time basis, unless we do a more seroprevalence surveys, more regular, it cannot be a 6-monthly exercise across few districts of the country. It must be systematically done and more comprehensively. The other is the genome sequencing itself. The fact that a lot of information on Delta is really on account of subsequent, the UK studies, which we are all looking at. And yet, it was here in January. And I think timely information and timely dissemination can help us overcome a lot of this hesitancy. And then, of course, the gorilla in the room is the politics itself. When politicians say they're not going to get vaccinated or it is Modi vaccine, it really does a great disservice.
So last two questions. One is, in post-pandemic economy, should India concentrate more on manufacturing rather than a service sector in the longer run?
No, I think that is it's a myth that has been propagated also within policy circuits, that India will be that one shining exception to the global sort of the historic development path of economies, that we will completely jump over the manufacturing and go straight to services. And that is because you have a very large agricultural, rural, unskilled labor force that is better absorbed into manufacturing at low skills and semi-skills than trying to make everyone work in services. Services is high growth. And I think most states are now competing for services and doing well in services, but there's no ignoring manufacturing.
Okay. One last question, which we all have been wanting to ask you. I know nobody is a magician or a soothsayer to predict things, but then as a doctor, we are tired of seeing all these COVID patients. Frankly, we are just frustrated working, and we are tired of seeing deaths. And will the third wave really come, and will it be really bad? One, two, where is it going from here for our economy? If third wave comes, will it devastate our nation? Or what do you think it is?
So Dr. Natarajan, let's be very honest to each other. Many people who have been studying this virus and the data closely had said there would be no second wave. And yet we were hit by the second wave. So let me tell you, as an empiricist, as an economist, I will not forecast. I have never forecasted. I lay my faith in the 7-day moving averages or the 10-day moving averages. meaning we've got to be on our toes. If the numbers have started rising in Amravati in January, the fact that we allowed for, this massive unlock, huge gatherings, there's a lot of fatigue even in media. We have a new paper coming out which talks about the role of media in a pandemic. And I'll take you back to Amartya Sen's very important work, which said that there is a reason that India, despite being a much poorer nation, has not seen a famine of the kind that China had seen. And the reason we haven't seen that is because we have a free media. And unfortunately, in the current situation and in COVID, we are seeing that the fatigue is everywhere, Dr. Natarajan. It's not just amongst the health workers and let's say the health community. The fatigue is widespread. It is there in the public at large, which is sick of being indoors and limited in activity. It is definitely there in the larger media and government and others. I will not forecast because I really don't. There are so many variables. Even, let's be honest and admit that the virus itself is the biggest unknown in terms of the way it is mutating. But having said that, we are seeing what is happening in some of the richer nations. They were very badly hit. And yet, with greater coverage of vaccines, they are seeing relatively fewer hospitalization, relatively fewer deaths. So going by that scientific evidence, let's just, follow that path, which is why vaccination is really seen as the way out of this. But it's a very large country. To say that third wave will not come would be quite, naive. It would be. So we will see third wave. The issue is, where will that third wave happen, and can we localize it at that particular district and that state, and don't let it spread and become another sort of national emergency. So yeah, I will stop there.
Thank you very much, madam. Over to you, Dr. Tina. Start.
Thank you, ma'am, for sharing all the nitty-gritties in a simplified manner and giving us a clearer perspective. Our next speaker is the topmost virologist of India, Professor Dr. Shahid Jamil. Presently, he is director of the Trivedi School of Biosciences at Ashoka University, India. He did his PhD in biochemistry from Washington State University, USA, and his postdoctoral work in molecular virology from the University of Colorado Medical School, USA. He received the Shanti Swarup Bhatnagar Award in Medical Sciences, which is India's highest mid-career research award. He enjoys interacting with people, communicates well, and has the passion to train the next generation. So, he is the person who will answer all our queries regarding the virus variants, success of vaccination, and prepare us for the future. Please welcome Dr. Shahid Jamil. Over to you, sir.
Thank you very much for the invitation. And I was listening to Dr. Ravi, and she has set up such a nice platform for me to speak to you about vaccines and variants. So let me just share my screen and get started. Are you able to see my screen well? Okay. So I will be speaking about COVID vaccines and viral variants and what the effect of the variants are on the vaccines that are currently available to us, both globally and more from the Indian perspective. Well, let me take you back to your early days of medical school. What is a vaccine? It's good to refresh our memory. The picture on this screen shows you the historical picture where Edward Jenner is taking cowpox material from a milkmaid and putting it on the hands of a 6-year-old James Phipps to vaccinate him against deadly smallpox. And this happens, I think, in either 1796 or 1798, towards the later end of the 18th century. Now, that was an inactivated vaccine. That was a live attenuated vaccine, I'm sorry. A cowpox, which looks similar to smallpox, but doesn't cause the kind of disease that smallpox does. So a vaccine really is a biological preparation that induces our body to provide active immunity to a pathogen when we encounter the real pathogen at a later time. So therefore, it contains something that is similar to the pathogen, and it stimulates the body's immune response. As you know, there are two parts of the immune response. We develop both antibodies and killer T cells. What antibodies do is to neutralize extracellular pathogens, and what killer T cells do is to destroy the infected cells that continue to be the reservoirs of infection. How immunity works is that if we have been immunized against, let's say, certain pathogens, and we receive a number of vaccines as children, so measles, chickenpox, some of us take the flu vaccine annually. So when our body has experienced these pathogens, even though the effector response may decline, the body still remembers. So there is a memory. And that memory is because while the effector response goes down, our immune system stores some memory B cells and some memory T cells that can very quickly give rise to antibodies and killer T cells when the same pathogen is encountered again. So vaccines for which we have, diseases for which we have taken vaccines, we can neutralize them fairly quickly. And although we may get infected, we don't usually get disease. However, when a new pathogen like SARS coronavirus 2 comes into the population has never seen this pathogen. There are no antibodies, there are no T cells, and therefore there is no memory. And the pathogen invades us, it multiplies very effectively in our body, and it is able to get transmitted from one person to another. And at a certain rate, it causes many people to be sick. And unfortunately, some of those who are sick get very sick and die. And this is what we are seeing with the COVID situation right now. So a vaccine is made by usually taking a portion of the pathogen, in this case a virus. And to be more specific about the COVID virus, the protein that covers the surface of this virus, which is called the spike protein, that either the entire protein or parts of the protein are taken, and there are various ways in which our body is made to make this protein and therefore raise an immune response to this protein. And it is that immune response that eventually protects us. So that's what we're doing. But before I get to that, I also impress upon you the value of vaccines. First of all, from an economic sense, vaccines are the most effective public health tool. And it is estimated that for every dollar that we spend on vaccines, it brings in a return of about $44, because children who otherwise would be sick grow up into healthy and productive adults and bring that to the economy. Now, if you look at this figure, what it shows in different rows are different diseases. And if you see from top, it can be mumps, hepatitis A, rubella, chickenpox, measles, and so on and so forth. Let's take measles as an example. You see that in the 1940s and 50s, even up to 1960, there was a lot of incidence. There was a very high incidence of measles globally. And that is represented by the size of the blue circles. However, when a measles vaccine was introduced, and I believe it was introduced somewhere around 1963 or something, and that's shown by the yellow circle, from then onwards, the incidence of the disease globally declined dramatically. And the same thing happens across diseases. If you see chickenpox, that's the same issue. If you look at polio, for example, polio is one disease that has been eradicated, almost eradicated. There are only 2 countries in the world now that have any wild type polio circulating. The same case with smallpox. We have been able to eradicate smallpox by some very focused vaccination campaigns. And by 1980, the world had declared itself to be free of smallpox. India stopped vaccinating in 1978 when it became free of smallpox. So vaccines work. Now, to COVID vaccines in particular, this figure shows you a representation of what the virus possibly looks like. It belongs to a family of viruses called coronaviruses, which express one major protein on their surface. And that protein shown in the orange illustration here is the spike protein. Now, the spike protein is not a single protein. It's actually a trimer of 3 identical monomers. So it is this trimeric unit that comes together as a spike that projects out from the surface of the virus. And shown in more detail here, it forms a surface that allows the virus to bind to certain cells and to enter those cells. So the way the virus enters cells is to bind to certain receptors present on the cells. And these receptors are shown here in yellow. These are the ACE2 receptors, which bind to the spike shown here in red. And once this binding takes place, certain conformational changes happen in the protein, which allows the viral membrane to fuse with the cellular membrane. And that is how the genetic material of the virus is injected into the cell. And that is the first step in the multiplication of the viral genome, and therefore multiplication of the virus, replication of the virus in our cells. So if we are able to limit the binding of the spike protein to the receptor, then we will limit entry of the virus and therefore cut short its life cycle. So it's really that simple, that if you have antibodies that can block this binding, then those antibodies will protect. And this has been the strategy for all vaccines that are in development or have been approved. So if the illustration here shows you a representation of the virus with its genome inside and the spike protein sticking outside, the first type of vaccines in development are the whole virus vaccines. And traditionally, these sorts of vaccines have been in use for almost 200 years, more than that, 300 years now. Among the whole virus vaccines, there are 2 types. One is the live attenuated vaccine, the example I gave you of cowpox being attenuated for smallpox. Another very good example of a live attenuated vaccine is the oral polio vaccine, which has been used extensively around the world, including in India and the Pulse Polio program to eradicate polio. The second type of vaccine is an inactivated vaccine. And here what you basically do is grow large amounts of the native virus. You chemically inactivate the virus and then use that as a vaccine. And this is what we know in India as the the Covaxin made by Bharat Biotech. Another type of vaccine that has gained prominence primarily during COVID are genetic vaccines, particularly the RNA vaccines. And you are all aware of the Pfizer and Moderna vaccines, which take a piece of RNA that can go into our body and into our cells and make the spike protein from within our cells. And it is this spike protein that then raises an immune response. There are DNA vaccines also in development, and one good example is the Zydus Cadila vaccine, which has undergone phase 3 trials in the country. We are awaiting approval of this vaccine. That goes one step back. So the DNA, when injected into our cells, makes the spike RNA. The spike RNA makes the spike protein, and that raises immune response. The third kind of vaccine is a viral vector vaccine. And here the most popular vector has been a cold-causing virus called adenovirus. And there are several vaccines that have been approved that use adenoviruses to send viral DNA, the coding for the spike protein, into our cells. And when this virus, think of it like a Trojan horse, when this virus delivers that DNA into our cells, that DNA gets transcribed and translated into the spike protein, and we raise immune responses. Now, an adenovirus from chimpanzees has been used in the Oxford AstraZeneca vaccine that we in India call Covishield. The Sputnik vaccine also uses an adenovirus, but that's a human adenovirus. And so does the Johnson & Johnson vaccine and several others that are under development. And the final type of vaccine traditionally has been a protein vaccine, which could either be a soluble protein or a virus-like particle. There are several vaccines. I mean, one of the best examples of this is the hepatitis B vaccine that all of you doctors must be immunized with. And that was also the first vaccine made using recombinant DNA technology. In the current context, the Novavax vaccine can be thought of as a virus-like particle. It's not a natural particle, but it's a particle that is assembled, a nanoparticle that is assembled after the spike proteins are expressed and purified. So these are the different kinds of vaccines that are in development. And as of a few days back, here is the tally. There are 8 vaccines that have been approved for full use. 8 vaccines are in early or limited use around the world. And there are over 100 other vaccines that are in various stages of clinical development around the world. The leading vaccines at this time are given in this table. You of course know about the Pfizer and Moderna RNA vaccines. You also know about the Oxford AstraZeneca vaccine, or Covishield for us. You know about Bharat Biotech vaccine, or Covaxin. And there are several others, some Chinese vaccines. Novavax has not received an approval, but this appears to be a very promising vaccine. You know about the Johnson & Johnson vaccine, the Gamaleya, or the Sputnik vaccine. So there are several vaccines available to us. And this has really been the defining feature of this particular pandemic. This is the first time in history that we are going to control a pandemic with vaccines. It has never ever happened in history. And that's largely because technology is developed to a point where we no longer take 10 to 15 years to make a vaccine, but hundreds of vaccines have been made within a year of the discovery of this virus. Now, coming to vaccinations, this world map shows you how countries have been vaccinating. And as far as equity is concerned, you can see very clearly that Africa has not received very many vaccinations, whereas Western nations, China and India, have been vaccinating at a good scale. And it's really something for us to be proud of, that India now has surpassed US in the number of doses that have been delivered in India. And this is a little over 320 million doses have already been delivered in India. since we started vaccinating in mid-January. The problem, however, is that our population being so large, we have only been able to vaccinate a small fraction of our population. But hopefully, as time goes on, we will get over this and possibly cover all adults who need to be vaccinated during this year. Here I show you how we have vaccinated over the last 30 days, and this is data from the Covin dashboard. If you look at the top figure, it tells you how many first and second doses we have delivered. So the blue here is 1 dose, and the light blue here is the second dose. But the thing to see is that our vaccination has gone up and down, but we have given roughly 300 million, roughly 3 million doses on average every day. On 21st of January, we actually gave more than 8 million doses, something like 8.6 million doses in a single day. And since that time, we are giving over 5 million doses every single day. So at least this tells us that we have the capacity to ramp up vaccination, because we will need to vaccinate somewhere around 8 to 10 million people on a daily basis if we are to vaccinate everyone who needs to be vaccinated. The lower graph shows you doses by age, and you can see that 18 to 44-year-olds have started to get much more vaccine now than in the past. Those who are above 60 have also come to a very stable equilibrium as far as vaccination is concerned. So we have the capacity to do it. As long as we have supplies coming from the back end, we should be able to vaccinate at scale. So let me talk to you a little bit about the genomic diversity in the virus, the variants that we're talking about, and how that affects vaccines. So we know that this is a coronavirus. The highest identity has been to some viruses found in bats. And if you compare it to other human coronaviruses, then the one that came in 2002, the SARS-1 virus, is about 80% identical. The MERS virus that emerged in 2012 has about 55% identity. And the common cold coronaviruses, and there are at least 4 that cause the common cold in human population, they have only about 50% identity to this virus. I'm not going to go into the genetic architecture, simply to say that the genome is roughly 30 kilobases, and it is one of the largest genomes in RNA viruses. Most RNA viruses have a genome of about 10 kb, but coronaviruses have roughly 3 times size of the genome. And because of that, it codes proteins like an exonuclease that also has some proofreading function, which means that it can correct errors, and therefore the evolution rate of this virus is much less than the evolution rate of several other RNA viruses. This is just to show you that there is a lot of genomic diversity that has developed in this virus ever since it emerged in the population. A lot of this diversity is focused in the spike protein, and it is estimated that ever since the virus emerged, there are roughly 750 different mutations that have happened in the spike gene itself. But of course, the mutations are not limited just to the spike gene, but also to several other structural as well as regulatory genes, and of course, the non-structural genes, which provide enzymatic functions. So at this evolution rate, it is expected that the virus mutates about 2 to 3 times per month. So roughly once every 2 weeks, you see a new mutation. Now you might ask, if the rate is so slow, how come we have so many mutations? And the answer simply is that the virus is very transmissible. it has infected almost 180 million people around the world. So there is a lot of opportunity for the virus to infect and to multiply. And therefore, the slow rate of multiplication is really a slow rate of mutation is made up by the high rate of multiplication. And this is the kind of genomic diversity you see ever since the virus emerged in late 2019. The virus that is floating in the population now has diversified a lot from the virus that emerged from Wuhan. And what we now begin to see are these variants of concern that I have pointed out on this map, showing you the alpha variant which first emerged in UK, the beta variant which first emerged in South Africa, the gamma variant first emerged in Brazil, and the delta variant first emerged in India. And there are these 4 variants of concern. Their circulation is now global, so no variant of concern is limited to the country where it emerged or neighboring countries, but it has really, every single variant of concern has gone global. Let's talk a little bit about this B1617 lineage, which first emerged in your state of Maharashtra in India. It was first seen in December 2020, and very quickly, within about 3 months, it emerged into 3 different sublineages that we call 617.1, .2, and .3, out of which the .2 lineage is now the Delta variant of concern. The way to read this box is if the color is dark, that means that that particular amino acid change is present in all of these lineages. So for example, the D614G is present all across, and in fact, in all viruses that are circulating now. However, if you look at, for example, T478K, this is missing from the .1 lineage, missing from .3 lineage, but it is present in the .2 lineage. And this is how it was first found out, because breakthrough infections in hospitals among people who were vaccinated with both doses showed predominantly that it was this mutation that was coming up. So it was essentially the Delta variant that was causing breakthrough infections. All of these also have this particular change, which is the L452R, and also the 681R emerged in these sublineages, but was not found in the parent lineage. What I show here in this figure is the trimeric complex of the spike protein from a top-down view. So you're seeing it, the surface that is seen by the receptor when the virus docks to the receptor. And what you see in red here are surfaces that come into contact with the receptor. And many of these mutations, in fact, all of these mutations map to that region. So some of these mutations have the ability to increase the binding to the receptor, like the 452. And there are other mutations like E484 and also the T478, which allow the virus to escape pre-existing antibodies. In India, we see how these different lineages have worked out over time. We see that initially we had the B or the B1 lineage, but slowly the UK lineage of B117 took hold. And from early this year till now, it is the Delta variant and it's the sublineages of the 617 that have become the predominant circulating lineage in the country. And it has really outcompeted the alpha variant in places where it was co-circulating. This is how various lineages have come up. And the important thing to see is that this 617.2 lineage, which is the Delta variant of concern, while it was first seen in December 2020, it didn't really start rising in the population till early March. And from there onwards, it had an exponential rise in the population, causing really the second wave. But of course, it's not just the variant that caused the second wave. Our complacency also caused the second wave, and our inability to wear masks and the inability of the government to control super spreader events like elections and the Kumbh were also responsible for the very dramatic increase in the Delta variant of concern across the country. But now a new lineage is developing within Delta, and this is called Delta Plus. So Delta Plus essentially is the Delta lineage, which is 617.2, with an extra mutation. And that extra mutation is right here, K417N. You see that it is present in the Delta lineage or the AY1 lineage, but it is missing from these Delta lineage, it is missing from the Alpha lineage, but it is present in the Beta lineage, or the one that was first seen in South Africa. So essentially, it is, there is a mutation that was first seen in the Beta lineage that has now, or in the Beta variant of concern, that has now also emerged in the Delta variant of concern. So that is the real concern, that you have mutations from two different variants of concern coming together into a single lineage. As far as the Delta Plus lineage is concerned, recent reports are that there are about 50 different sequences that have been found in India, out of which 22 have been discovered from Maharashtra, and several others from Tamil Nadu, Kerala, Madhya Pradesh, and so on. 50 out of about 45,000 sequences that have been done from India is only 0.1%. So on that account, we need not worry. But if we go back and see what happened to Delta, and if I take you back to this figure again, Delta was a very small fraction in December, but by March, it overpowered everyone else. So would Delta Plus do the same? We don't know that, and that remains to be seen. And that is why it is very, very important for us to remain cautious and to follow this very, very closely. Okay, how about the infectiousness of the different variants of concern? So if the original SARS virus, which emerged in 2019, let's say had a transmission ability of 1, we have come to the Delta variant that has that is about 2.5 times more infectious than the original virus. So if this is the virus that seeded the first wave in the country, this is the virus that seeded the second wave. And this is a very logical and clear explanation for why we saw 4 times the number of cases at peak in the second wave compared to the first wave. So finally, do current vaccines work against variant viruses? And I'll show you this model of vaccine efficacy. As vaccine efficacy, as the neutralizing antibody titer increases, the protective efficacy of a vaccine also increases. So let's say this is the efficacy of the original strain. This will wane off with time. This will go down with age, and this will also go down with comorbidities. But let's say the Delta comes somewhere here, reduced about 6 to 8-fold reduced efficacy of the antibodies. But But the point to make is that there is still sufficient protection afforded by current vaccines to the population, because the amount of antibodies we make on vaccination are much, much more than what you require to neutralize the virus. And similarly, this efficacy will also go down with time, with age, and with comorbidities. So let us look at some real life data, some real world data. And this is a study from Public Health England. I'll take your attention to the top table. And they tested the Pfizer vaccine and the AstraZeneca vaccine against the Alpha variant and the Delta variant. So 1 dose and 2 dose give increasing protection, so about 50% to 90%. Similarly, the Oxford AstraZeneca vaccine gives about 50 and about 67% 2 doses against the Alpha variant. You come to the Delta variant, you see only 33% protection with 1 dose, about 90% with 2 doses. And that's the Pfizer vaccine. With the AstraZeneca vaccine, you see about 33% and roughly 60% protection with 2 doses. But mind you, this is against symptomatic disease. Now, let's reduce the stringency and let's look at how effective vaccines are against hospitalization. So essentially the same study, Pfizer and AstraZeneca vaccine against the Alpha and the Delta variant. And you will see that even a single dose of either vaccine affords very good or reasonable protection against severe disease and hospitalization. And this is really the scientific basis for extending the dose, the gap between the 2 doses of Covishield in India to 12 to 16 weeks. And the point is that since vaccine supplies are limited, we try and vaccinate as many people as possible instead of being able to vaccinate only a smaller proportion with both doses. And so this is the scientific basis, and it's right to increase the gap between the doses. The same thing, so this is actually 4 different studies from UK. The Public Health England study that I just showed you, a Warwick study, London School of Hygiene and Tropical Medicine study, and an Imperial study to show vaccine effectiveness against hospitalization from the Delta variant, both Pfizer vaccine and AstraZeneca vaccine. And the point again is that both vaccines afford very good protection against hospitalization for people who are infected with the Delta variant. A study from India, from CMC Vellore, again looking at different endpoints: infection, hospitalization, whether somebody needs oxygen, needs ICU, and mortality. Unfortunately, in that study, they did not break the study up into Covishield versus Covaxin, simply because the numbers of those vaccinated with Covaxin was so low. But the point here again is that whatever vaccines people are getting, 1 dose and 2 dose offer reasonably good protection against severe disease, hospitalization, and mortality. A PGI study which was done at the time the Alpha variant was circulating among healthcare workers, about 500 healthcare workers, showed that giving the vaccine gave about 80% protection to healthcare workers, people who work in a very highly infectious surrounding. And finally, a study done by the Apollo Hospital Network in about 31,000 vaccinated healthcare workers also shows that vaccines offer very good protection against serious disease and deaths. So what are the things we know about the Delta variant and the things that we don't know about the Delta variant? Well, first thing we know about the Delta variant is that it is spreading very rapidly around the world. So in India, as you have seen, it is the major circulating variant. In both US and UK, it accounts for more than 20% of the variants of concern that are seen in those populations. The virus appears to be more transmissible. It may be associated also with different symptoms, and studies from China have reported more sort of severe symptoms with the Delta variant. And those studies also show that people with the Delta variant may also be more likely to be hospitalized. I have shown you data that one dose is less effective, but still offers reasonable protection, and 2 doses continue to protect. What we don't know is whether the Delta variant is associated with increased mortality. And we also don't know whether booster shots will be needed a year from now, 6 months from now. We don't know those details. So in summary, I have listed here the ancestral virus and the various mutations or the lineages that have come up, their transmissibility, ability to evade immunity, and whether vaccines are effective or not. So the bottom line is that the Delta variant, even though it is highly transmissible, it also evades immunity reasonably well. Vaccines continue to protect against this variant. Now, whether Delta Plus is going to further increase its ability to transmit, and whether the immune evasion by Delta Plus will be bigger than what Delta has shown really remains to be seen. There aren't enough cases in the world at this point to reach those conclusions. So I'm going to stop here, and if you have questions, I'll be very happy to answer your questions.
So thank you, sir, for an extremely informative lecture which you have taken. And there are indeed a few questions for you. And one of the most commonest question which patients have also been asking us, and many people are asking us, is that which vaccine do you consider the best, Covaxin or Covishield? So what would you say for that?
I'll tell you about the science, and you are all scientists. You can make your own judgment. Any killed vaccine will not make very good killer T cells. So while both vaccines will raise good antibodies, and there are studies already available that both Covaxin and Covishield raised very good antibodies, Covishield will give you better killer T cells. In fact, there are some studies that have looked at all the vaccines and their clinical trial data, and have come to the conclusion that while the RNA vaccines give the best antibodies, the AstraZeneca vaccine gives the best killer T cells. So with Covishield, you're actually getting both antibodies and killer T cells. With Covaxin, you're getting only antibodies. You won't get killer T cells because that's the nature of the vaccine. However, before you reach any conclusion, I must say that in real world tests, both vaccines are working quite well.
Okay, so one more question is from Dr. Rashida. She is asking whether which environmental or host factors are possibly helping the virus evolve so rapidly.
Well, one of the things that is allowing the virus to evolve so rapidly is the sheer number of infections around the world. If we reduce transmission, if everyone wears a mask, if we don't have big gatherings and reduce transmission of the virus, the mutation will also go down. So that's the number one culprit, that there are so many infections happening. Now, having said that, any virus does not have unlimited capacity to mutate. After all, the genomic space in a virus is very limited. What we are actually seeing is a very small fraction of the mutations that are happening. Most of the mutations are deleterious to the virus, and we never see those viruses. We are able to see only those viruses which give some advantage in terms of better transmissibility or slightly better evasion of immunity. Those are the only viruses we are seeing. So I think what we're seeing right now is a virus coming to equilibrium with the host, and in due course, we will see that the virus will reduce its virulence and become an endemic virus, just like earlier coronaviruses. Now, whether that will take 5 years or 10 years or 50 years, I don't think we can predict that. But that is going to be the natural progression of this virus.
Okay. So there's one more question from Dr. Suhas. He's asking whether there's been recent studies like Covaxin and Covishield. So first dose is say Covaxin and then the second dose is Covishield. So whether this type of this type of protection will be better than 2 doses of the same vaccine.
Yes, so we don't yet have data with Covaxin and Covishield, but we do have data with the Pfizer vaccine and AstraZeneca vaccine. And that data shows that whether you give the first dose as Pfizer and second as AstraZeneca, or you reverse it and give first AstraZeneca and then Pfizer, in both cases you get similar antibody responses. And those are better than either vaccine alone. But these studies also show that mixing vaccines also increases reactogenicity. So you get more, side effects for the vaccines. We'll have to wait to see what the Covaxin Covishield data shows. But as far as immunology is concerned, it's perfectly all right to mix vaccines. In fact, the Sputnik vaccine is sort of a mixed vaccine because it has 2 kinds of vectors. The first dose is given as an adeno 26 vector vaccine, and the second dose is given as an adeno 5 vector vaccine. So in any case, that's sort of like a mixed vaccine. So yes, it's very much possible to do mixing. There is nothing in immunology against that.
Okay. And so recently there has been a lot of discussions like the third wave is going to affect the pediatric population more. And so we should be giving them influenza vaccines, as a protocol. So like, what do you suggest for this?
Well, I have to say 2 things. Firstly, there is no scientific basis to say that children will be affected more in the third wave. I think most people are saying this because in the first 2 waves, a lot of adults have shown symptomatic disease. But we have really very poor understanding of how many children actually got infected during the first wave and the second wave. Like many other viral infections, COVID also does not show very much symptomatic disease in children. And the scientific basis for that is that the ACE2 receptor, the expression of the ACE2 receptor increases with age. So in very young children, you have very little ACE2 receptors. And as children become teenagers and adults, the amount of ACE2 receptor increases on their cells. So it could simply be that. So I have not found any scientific basis to say that the third wave is going to affect children more. As far as influenza vaccine is concerned, there is no real evidence that influenza vaccine protects from COVID. Possibly in the short term, all it does is to raise our innate immunity, and that is what people are banking on. As far as the third wave is concerned, what are going to be the drivers of the third wave? Well, the drivers of the third wave would be both private drivers, such as our inability to wear masks and congregate in high numbers. It would also depend upon public policy, which is our ability to give vaccines very quickly. And the third would be whether a more infectious variant emerges in the population. Delta plus, I don't believe is that variant which is going to be significantly more infectious than Delta. Just like Delta was significantly more infectious than the parent virus or Alpha, I don't believe Delta plus is going to be far more infectious. So right now, I think all of this is conjecture that the third wave will happen in mid-July, or the third wave will happen in 6 weeks. All of that is conjecture. It will really depend on multiple things.
Okay, so we hope that the third wave never comes. So one more question by Dr. Jyoti is again, like, how much period does vaccination afford immunity? And booster doses, again, I think we have answered that question. So how much period does vaccination afford immunity? That's what she's asking.
Sorry, I missed part of the question. How much?
How much period does vaccination afford immunity against COVID?
Well, we don't know the answer to that question, really.
True,
The disease is only 1.5 years old. Vaccination is only 6 months old, maybe. So we don't really have data to address that. As far as the infection is concerned, the data that is coming out now is that even 1 year after natural infection, people have very good quality memory cells, both B and T memory cells. So hopefully vaccine will do even better than that.
So that makes us come to the next question, which is related. So it's so we were wondering that whether, like, since we have seen very few cases of reinfection occurring in people, so once they've got the infection, there's a very less chance that again they will get infected. So do you think that the vaccine policy should be tweaked, like people who are have already got an infection, whether we should avoid giving them the dose and instead vaccinate other people first? So.
Well, the trouble with that is that, you would have to test everyone, find out who has been infected naturally. Not everyone who's infected naturally gets symptomatic disease. In fact, over 80% people show no symptoms. They are asymptomatic. So, you include another variable, and the logistics of that is going to be quite atrocious. You will also need very highly sensitive antibody tests to be able to figure that out. So I think India is a very complex country in terms of our public health needs and delivery. And it is always good to have public policy which is fairly simple. So finally, we have a situation where vaccines are available to everyone. Vaccines are available free. You don't have the center versus state versus private divide. All that adds to the complexity. And that is why now we are seeing much better vaccination rates than we were seeing just a few weeks back.
Okay. And so one last question. So Dr. Mandar Kubal has said that there's a recent study in which it is said that SARS-CoV-2 variants are selecting spike protein mutations that increase protein stability. So he has a question that will this be an hindrance with first generation vaccines as time progresses, and should we invest preemptively in second generation vaccines?
Well, I believe vaccines will have to be improved with time. But we have to rely on real world data that is coming through. And at this time, the real world data shows that currently available vaccines are protecting quite well. So I don't really think there is any cause for alarm right now. And I might just end by saying that many of us get very worried about this variant or that variant, whether a vaccine will protect against this variant or that variant. There is a tool that protects against all variants, and that is a mask. And we don't use that simple tool as effectively as we should be using. So let us not worry about too much about vaccines and variants. Let's continue to protect ourselves.
Thank you, sir. Thank you for patiently answering our questions. So over to you, Dr. Tina.
Thank you.
Thank you so much, sir, for your excellent talk and demystifying the virological aspects of COVID-19 infection. Lastly, our final lecture would be a panel discussion on the COVID topics. We have esteemed panelists lined up for today's panel discussion. Dr. Ashit Hegde is a consultant internal medicine and critical care specialist at Hinduja Hospital, Mahim and Khar. He is a recognized teacher for certificate course conducted by ISCCM and a DNB teacher. His areas of expertise include ARDS and severe sepsis. Dr. Santosh Kadam is amongst prominent pediatricians of Thane. He is presently the president of Indian Medical Association Thane. His experience in the field of pediatrics and neonatology is of more than 2 decades. Dr. Ashish Bhumkar has more than 25 years of experience in the field of ENT. He is a teaching faculty in Singapore, Zurich, and France. He is a pioneer in the mycosis surgery, appointed the Maharashtra Task Force head on Mucor Mycosis. Now, we will begin with the panel discussion.
Very hearty good afternoon to all the esteemed panelists. I hope you are all able to hear us clearly. Yes. Am I audible?
Yes.
Yes. So I think we will start with a couple of questions. We have had lots of questions, almost 40-50 questions are waiting. So the first question is to Dr. Ashit Hegde, sir. Welcome to our panel discussion. So what for over the last couple of months we have been managing these patients of ARDS, and what we have seen is those patients who have been intubated, put on mechanical ventilation, have very high mortality. So what is the time that you would want to shift the patient on mechanical ventilation? Would you even go to, say, like some intensivists out here, they are saying we should avoid mechanical ventilation till the last step. I mean, try to manage them on BiPAP or NIV or HFNC. What is your recommendation for this?
Actually, I think even I went through that phase where initially I was very reluctant to intubate people. But I finally noticed that actually probably the indication of intubation should be the same, whether it is COVID or some other, ARDS, any other respiratory distress. When there is evidence of respiratory distress, which means there is, paradoxical breathing, very high respiratory rates, clearing of the alia nasa, accessory muscles are being used, I think you should intubate. The problem really is that with COVID, the problem is because infection control is so poor, many of these people, develop secondary infection. That is why the dilemma occurs. If hadn't been a non-COVID situation, there was no question. My real dilemma is that when I intubate them purely because of, very poor infection control in ICUs, there's a little higher risk of, secondary infection. But even having said that, I would say that, I wouldn't, quite often, too much of spontaneous effort itself promotes lung injury. A lot of people on NIV taking very high tidal. If you look at the many of the patients on NIV, the tidal volume will generate a 600, 700, 800, which are pretty damaging to the lungs, actually because of secondary ARDS. So I think, by and large, I don't think this thing about delaying intubation as much as possible is right. I think by and large, if you intubate when you think they're having signs of respiratory distress, when the tidal volumes are very high, the respiratory rate is more than 35, flaring of alia nasa, secondary muscles, but try and focus a bit more on infection prevention. That's what the thing is. Whatever you can do to prevent infections.
Okay. So next question is to Dr. Bhumkar, sir. So we all know that India has become the Mucor capital of the world. That is what they say. So what common predisposing factors you have seen in all these patients who have come to you?
Thanks, Poonam. Yeah. So India has not become the Mucor capital. It has always been the Mucor capital. Incidence of Mucor in India is 80 times more than any other average country. This is pre-COVID times. So for whatever reasons, which we know, India has always been that. Now, specifically in this particular time of COVID that we are seeing, it really comes down to the one is something that the variant is doing, which primarily we don't understand, which is what is doing to the immune dysregulation and glucose dysregulation. This was, I think, the primary step that happened. Over and above that, what happened in the early until Mucor showed its face to us was that we as clinicians, and rightly so, we were not really worried about sugar remaining high for a few days or a few weeks. And that privilege of allowing it to be high is no more there now. So on a daily basis, when you control the sugar, then the mucor disappears. It's already gone. Almost 70% of mucor is gone now. What we are seeing is only the residual which is coming back because the sugar controls have been excellent in the COVID center.
So, but in one, this was that many of the patients, as you all know, in this last 1 year, they have been taking too much of steam and too much of gargling. So once it was postulated that whether this has become, a risk factor for
I
mucor.
call it mucor is only and only a host factor dependent opportunistic disease. All these other things about steam and gargle and oxygen and the humidification, I call them as the ghost factors. It's good. The human mind always tries to find something of a button that it can very easily put on and put off. But mucor is a host centric disease, opportunistic host centric disease.
Okay.
Steaming has got nothing. Steaming doesn't help, but it does not do any damage either.
Okay, sir.
Okay, the next question is to Dr. Santosh Kadam, sir. So this, we all have been hearing that now the children are going to get affected in the next wave, if at all, if it comes and when it comes. So what is this MIS? I mean, for adult, I purely practice adult respiratory medicine. So what is this PIMS and MISC? I mean, I'm clueless. I have not even seen anything like that in adults. So what is it?
Primarily, COVID illness we categorize in children into two. One is acute COVID-19 and another is the sequelae, that is MISC, multisystemic inflammatory syndrome. When in the last, when there was a peak in the second wave in the month of April and May, I started getting many cases in the month of June, first week, as well as in the end of May. Many children came again with fever, which was without focus, which was running for 7 to 8 days. This we called as a multi-inflammatory system syndrome, COVID. Similarly, the same thing happens in neonate also, and that is called as MISN. So basically, the acute COVID-19 is very, very mild in children. They suffer from fever, just runny nose, vomiting, loose motion, and then recover. Many times it goes unnoticed. Many times we did test, but test come negative, and many times even parents don't go for the test. Usually this infection is already caught up from the parents who are suffering from COVID illness. So we should not worry about the acute COVID-19, that is primary illness. A very, very small percentage of cases develop what you called in adult as an lung inflammation. After one month to 3 months, again, because of the antigenic reactions, there occurs an inflammation, and usually it affects multi-organ. So that is called as MISC, and the treatment of management is to stop this inflammation either by giving steroid or by giving IVIG.
Okay. So our next question is from Dr. Kamal Chandnani to Dr. Ashit Hegde. What is the longest after COVID infection can the patient expect any complication, cardiac, neurological, or mucor, in presence of comorbidities such as diabetes and hypertension?
But I really think we're all learning. It's too early. This whole disease is new. We are still learning. So it's, we really can't say what is the longest. But if you look at the Mucor Mycosis, there was this study from all India study, but primarily by Atul Patel from Ahmedabad, where some patients develop Mucor Mycosis as late as 90 days after the attack of COVID. So I mean, it's very, very difficult. We don't really have enough data yet to say that after 3 months or 6 months, you're safe. Clearly, symptoms, there is something called long COVID, know that patients continue to remain unwell, for up to 6 months after recovery from COVID. But developing fresh symptoms after 2 or 3 months is unlike, except for, like I said, mucor, but developing a fresh, myocarditis or something after recovery is unlikely. The only thing that can occur after recovery, one is maybe mucor, which I think usually will occur within a month or 2 months, rarely can go up to 3 months. And sometimes you will develop a thrombotic episode, which also generally will happen within 1 month. I don't think it persists beyond 1 month. But some symptoms which began with COVID or began soon after COVID might persist for up to 6 months. But to develop fresh symptoms, except for, like I said, embolic episodes or, sometimes mucor, is a little unlikely.
If I may add, I think he's right. Ashit is right. Mucor, I think the highest incidence is 50 days. From day one of your symptom up to 50 days is the maximum. Between 50 and 100 days, the chance goes down. After 100 days, we can probably be relaxed. And, assuming, and of course, what is obligatory is to have your sugars under control.
100 days is also a big time. So one question from Dr. Yogesh Ghansham Chaudhary to Dr. Bhumkar sir. So he's asking whether you have seen any COVID patient with sensory neural deafness due to infection.
So it is reported. Personally, I have seen patients with tinnitus. Fortunately, his hearing was spared, but we have seen these. We have actually seen one patient after a Covishield vaccine. 12 hours later, he developed tinnitus, and in fact, he came to us. Now he's due for the second dose. Should he be taking or not? So these microembolic phenomena which are happening probably in the inner ear. Fortunately, no vertigo we've not seen or they have not reported, but SN loss is discussed in the ENT circuit. I think it's attributed to the microthromboembolic.
Okay.
Okay, Dr. Ashit Hegde from Dr. Sudharma Darvi, would we be seeing bacterial drug-resistant respiratory infections in great numbers in the future due to COVID?
I mean, in the future due to COVID, no, in the COVID ICU, we were seeing a lot of respiratory, not just respiratory, even secondary bacterial infections because of, like I told you, the main problem really is very poor infection control because everybody is in PPEs, they don't remove their gloves, they don't do proper hand hygiene. Everybody is, so all these infection control is taking a complete backseat in the COVID ICU. So we are seeing a lot of respiratory infections caused by MDR organism in the ICU. But I think that phenomenon should remain confined to the COVID ICUs. Once I think we're out of COVID, we're back to working without PPEs, back to taking the proper infection control precautions. Ideally, they should not matter. They should not happen. As such, resistance rates in our ICUs are pretty bad. I don't think it get any worse. But I thought it wouldn't get worse. In COVID, it did get worse, but that was, like I said, purely because of I think the infection control taking a backseat. Once we come back to normal, hopefully come back to normal and come back to implementing the standard infection control precautions, I mean, I think the resistance rate should remain where they are. In fact, community transmission of infections probably at TB, etc., because of masking, is actually probably, I mean, you all are the better to comment on those, the respiratory diseases, but I think you all are probably seeing less other respiratory infections.
Yeah.
So, I think while in the ICU at the moment, we of course are seeing a lot of resistant bugs. Hopefully, after we come back out of COVID, it should remain where it was before COVID. Not
Correct.
Okay. So one question from Dr. Jayendra Mao to I think Dr. Subramanian. So he's asked for how much time should we give anticoagulation if the D dimer is high?
So I think I already showed all my data and graph. In outpatients, we don't recommend doing D-dimers. If at all you want to do it only in severe comorbid cases or elderly, diabetic. And then even if it is high, if the patient saturation is normal, I think we should just wait and watch and do nothing. And inpatient has to be given to majority of the patients, at least as a prophylaxis, at least patients who are on oxygen and their D-dimers are not below 0.5, below 500, below 500, then there is, it has a higher negative predictive value. So inpatients, by and large, most of the patients get anticoagulation, but outpatients, no, we don't recommend giving anticoagulation.
Okay.
Okay. Now, the next question is to Dr. Bhumkar. Now, sir, we have heard that mucor cases require quite a lot of surgeries. Is it true? Is it like they need some 4 or 5 surgeries? First you remove the mucor, then again go inside, remove mucor, go in, remove plastic reconstruction. I mean, is it truly that? You may have done quite a few.
I think the question has an undertone of an exaggeration, but yes,
Okay.
it is not unlikely to need a second surgery, primarily because what mucor does, it starts to cause avascular necrosis. It starts blocking the arterial supply. The micro blood vessels are what get occluded, and then the corresponding tissue gets necrosed. So the surgery is about removing the necrosed tissue so that the acidic medium of the local area is gone, and two, that the drug can therefore reach, because through the necrosis the drug cannot reach. So what the MRI catches and what the surgeon sees is really just the necrotic tissue, but not the impending necrotic tissue. So what you see as normal and healthy to the eye, you don't remove. But over a period of time, those blood vessels can also get blocked, and there can be a second bout of a necrosis in other areas. And this is where the second surgery comes in. Very typically in this, we saw the palate getting affected like this. In our earlier pre-COVID mucor, we were not seeing so many palates getting affected. For some reason here, the descending palatine started coming in much later, and the palate started coming. So typically it was either that or a skull base, the orbital apex and the skull base. These were the areas which were showing necrosis at a later stage. And these are the only two anatomical areas where the second surgery was needed in some patients. Where the palate is concerned, they need a rehabilitation with obturators and building everything back. But that takes about a year and about 3 or 4 surgeries. So that's a long drawn surgical procedure for those patients. But the good news is that people who get palate as an involvement very rarely get intracranial complications, and therefore the mortality is very less. For those in whom it goes to the sphenoid and up, where perhaps the eye gets involved, for them the mortality tends to be a little higher. But where it starts to go down into the palate, these patients have higher morbidity in terms of the challenges of the palate reconstruction, but not so much mortality. Other change that happened is we could only remove the bone and preserve the mucoperiosteum. So they never had a oronasal fistula. So at least they were good. So they were on a Riles tube for 10 to 15 days, but otherwise they could eat a soft diet. But it's a tremendous misery that the patient of mucor. I mean, it's a much bigger war for that person, for that patient, to fight the mucor than the COVID.
Right.
Okay. So one question from Dr. Prajna to Dr. Ashit Hegde. So she has asked that whether a patient is already on AKT and he has got a COVID infection, so when should he take the vaccine?
AKT, I mean, as such, I don't think the TB makes any difference to the vaccine. After you have suffered from COVID, generally as recommended, probably 2 to 3 months after that, because by and large, infection itself gives you some protection from reinfection, at least for 2 to 3 months. So after 3 months, I think it's safe to take the vaccine. I don't think TB in any way influences your, eligibility for the vaccine. I mean, you all are the best people to answer this honestly.
No, it doesn't.
We always say that you can take the vaccine irrespective of any other underlying lung conditions.
For only COVID, but after 3 months.
Correct. So another question to Dr. Santosh Kadam. As a task force committee member, how is the preparation for the third wave in Thane? What are you predicting, and what are you going to do?
Okay. So for last from last March, we had a task force, and mostly all the super specialists and the physicians were there in the group. Now we have formed a task force, including pediatricians, and this type of task force has been formed at Maharashtra state level also. And the last 24th May, CM Uddhavji Thackeray attended that meeting for 2 hours. And they have come up with a very nice guidelines on the pediatric state task force, the pediatric state task force. A day before yesterday, we took a meeting from collector office and for the entire Thane district, and the pediatrician as well as the medical officers who are involved into the future care of pediatric children's. We have updated them about the further lineup management for pediatric COVID. So on one hand, this preparation is going down. Government is really thinking that there could be a third wave and more children will be affected. So they are coming out with PCC, that is Pediatric COVID Care Centers. So most of the children we target to manage at Pediatric COVID Care Center, that is PCCC, and very few maybe need to be shifted to PICUs. And in this way, we are establishing some of the PICUs in the center places. Like in Thane City, we are coming up with in Parking Plaza, 100-bed PICU over there. And similarly, Thane Municipal Corporation as well as all the municipal corporations are gathering information from the private hospitals that how many PICU and NICU bed you have. And accordingly, I think they are arranging for the critical care, pediatric critical care.
Okay. Okay, the next question is to Dr. Bumkar. Sir, from Dr. Sunil Sawant. Sir, we have had the first COVID wave following the second in 2021 March. Mucor mycosis cases are being seen only in second wave, in spite first wave lasting for years. Why have we not seen such fungal cases?
Yeah, for all the very reason that I said, and I think we should first of all think it's the variant which is doing something to the glucose dysregulation primarily, and this is a matter of investigation yet. Of course, the role of overuse of steroids or something did come in, because we did not know. It was not just the steroid affecting the immunity, but also keeping the sugars high. Because it is when I keep saying in the colloquial meetings, when your blood becomes a sugar syrup, I think that is where. So a lot of prophylactic use of steroids started happening right from day one of the thing. And I think this was that little we lost control over the judicious use of a steroid and the concomitant sugar control. I think this got compounded in the second wave. Perhaps there is an underlying role of the variant, and we will know now how this pans out. But that's the only explanation we have about why it did not come in the first. In the first wave, I think the role of steroid came only in June, July. From UK, the role of steroid came as a lifesaver. And I think as Indians tend to overdo on anything in pharmacotherapy, be it antibiotics, which is what your earlier question was. So also, I think there was a little bit overstress on the steroids. And I think now that we have brought it under control, immediately in less than 50 days, we are seeing a decline almost by 70% in the primary mucor mycosis.
Okay. So that's a good thing to hear that 70% cases are in the decline. So, okay. So next question is from Dr. Tarachan Pawar to Dr. Ashit Hegde. So he has asked, what is the role of methylene blue in treatment of COVID patients?
Well, at the moment, I mean, for treatment, we go by evidence. I mean, there are anecdotal reports from Surat claiming that methylene blue helps patients with COVID. Now, there might be some theoretical rationale for this, but honestly, in medicine, anybody who makes a claim really needs to back it up by publishing a paper showing clearly that, you have to do some kind of a trial to say, I mean, people get better for a variety of reasons. You can't attribute that they got better because of what you have given. Many of them get better. In fact, so I think there are anecdotal evidence, anecdotal reports about methylene blue, but really no, hardcore evidence to suggest that it improves matter. So at least unless I'm convinced by some paper which shows that clearly works, I would be reluctant to use methylene blue, at least in routine patients with COVID. Now, having said that, methylene blue is a very good vasoconstrictor. So in patients with refractory shock, I mean, whether it is COVID or sepsis, sometimes I have tried, I must admit I have tried methylene blue, but that's really in desperate situations where in refractory shock, clearly vasodilators, they have a bounding pulse, they have a high cardiac output. They sometimes have tried not responding to noradrenaline and vasopressin. I've tried methylene blue as a salvage therapy for refractory shock. But purely to improve the lung, to the hypoxia, etc., I have not used methylene blue. And like I said, for people have made claims, but I think they need to back up their claims with some, more publishing a paper or doing some kind of a study. So until that is done, I really won't be using it for the routine patients with COVID.
So to Dr. Poonam, Dr. Kirit Soni has asked, is it mandatory to get the second dose after 3 months post-COVID infection when the first dose of Covishield had already been taken before you were infected with COVID?
So I think right now all the guidelines mention that you have to take both the doses of the vaccine, even if you got infected in between, because we are still not sure like what virus, which variant infected you, and how much is the antibody level and how much protection it has given to you. So all the right now, all the I think studies and as well as the norms say that it is better to complete the vaccination schedule, because it is then confirmed beyond doubt that you have that much amount of and protection in your blood, antibodies, T cells, memory cells, so all they are there, so that it gives you a defined level of protection. So as we have Dr. Shahid Jamil showed in his slides, so 2 doses of AstraZeneca or 2 doses of Covaxin, and it gives a definitely very, very high protection against mortality. And so I think we should avail this benefit and complete our vaccination course.
Okay, one question to Dr. Ashit Hegde. In fact, we had a discussion on this when we were on our ICU rounds. So a lot of people are advising low PEEP in ICUs, and they say the target saturation should be around 88 or 85 to 88 is just acceptable. So what's your take on this? Would you give low PEEP, or would you follow the ARDS net protocol in giving higher PEEP?
So like, I mean, a lot of people have talked about this, that, probably COVID, there are 2 kinds of, in these early stages, it's really more a problem with the increased, vascularity. As has been mentioned, there's more vascularity. Even Bhavin talked about in his CT talk that the ventilation is not really an issue. That alveolus is hyperperfused, but the lung is reasonably compliant. So the problem is really that there is a VQ mismatching, but not because of low ventilation, but because of hyperperfusion. So at least initially on in COVID ARDS, they probably have a compliant lung. High levels of P probably don't do much good. So, but as the disease progresses, as the damage gets worse, then of course they become a classic ARDS. So at least early on, definitely I would use low levels of PEEP. I probably don't use more than 5 of PEEP early on. Later on, if the situation resembles the classic ARDS, then I might treat them the usual way. But I would of course resort to proning very early, even in the early ARDS. So I would prefer to use low PEEP and proning early. And as been said, I agree with this, that when you're monitoring a patient, and especially being monitored regularly, as long as the organ perfusion is well met, patient is conscious, his extremities are warm, is passing urine, there is no acidosis, I would accept saturation of 85% easily. In fact, if you're doing a PO2 55 is reasonable. You really don't need higher PO2 more than 55. But yeah, so provided of course everything else is being well, there's evidence of there's no evidence of tissue hypoperfusion. 55 PO2 or a saturation of 85 to 88 is more than adequate. I agree completely.
Okay.
Okay, so next question is to Dr. Santosh Kadam sir. So recently, when a lot of physicians and this pediatricians are giving budesonide inhalers for mild cases of COVID. So do you recommend that, and like what is your take on it?
Yeah, if you start inhaled steroids, if there is a lung involvement, it is helpful. But in in children's, you don't get involvement so commonly. So if you're asking for pediatric patients, yes, you can continue if there is a lung involvement, and it helps a lot rather than giving systemic steroids. But again, I'm repeating that lung involvement in children is very, very less as compared to adults. What is common is MISC. And what I feel is that even second, if at all the wave comes, mostly this admission will happen not in this thing, COVID hospitals, but we have to manage in non-COVID hospitals. But by that time, they are non-infected.
Okay.
So the next question is to Dr. Bhumkar. Sir, this Mucor requires a lot of doses of liposomal amphotericin B, and there is a huge shortage. So how are you managing, or are you giving posaconazole? I mean, how are you managing the things?
Now the supply situation is quite good. Primarily because I think the COVID has come down, Mucor has come down, and the state and the machinery is all in good place now. Now everybody every patient who needs it is getting the liposomal amphotericin. But we did go through a lot of jugglery. We went through modifications in our protocol, right from the imaging and microbiology to our surgical techniques, of having a surgical technique which allows you a better surveillance. So having a much wider exposure. So at every step of the treatment, we started doing modifications. One, because the volumes were big. Two, because the supply of the amphotericin was less. So we went through a lot. We started mixing. We started bringing in posaconazole earlier. Because we have this fantastic microbial lab in Thane, which is only second to the PGI, we started doing the subspecies of Mucor. Some species are more sensitive to or equally sensitive to posaconazole, and that advantage we took being in Thane. So we tried to do a lot of jugglery with the medicines. We also did what was very different and interesting about this Mucor, unlike the earlier pre-COVID Mucor, is the pre-COVID Mucor affected a nearly permanently immunocompromised patient, whereas the current Mucor affected a transiently immunodepressed person, and then the immunocompetency came up. So now we had Mucor existing in an immunocompetent body. Therefore, we started doing, instead of the 5 milligram, some centers started doing 3 milligrams, some 3.5. When there was no amphotericin available, there were amphotericin holidays or breaks dictated by the non-availability or by the renal function. And still the patient was stable and increasingly getting better. So it's a unique time in medical history where we've had a disease and the drugs were not available. So it's going to be an interesting retrospective study. But the immunocompetence of the patient, I think itself guarded the patient from the spread of the Mucor. This is what the whole scene was in the last few weeks.
Okay. So one question from Dr. Meenal to Dr. Kadam. What about vaccination for Indians traveling to US after 2 doses of Covaxin? So
yes, as Covaxin has not completed the third stage of trial, WHO has not given a recognition for Covaxin. So unfortunately, those who have got Covaxin shot, USA will not accept them. I think, but the third stage is nearing, and maybe that once the third stage is finished, they will the Covaxin, that is the company will submit the data to WHO, and hopefully they should get a recognition very soon. By that time, I think they have to go for second, that is Covishield, or else they can carry a certificate, like they can do neutralizing spike protein antibodies. And if they have sufficient, I think they should, the US administration should accept it.
Okay.
So one question to Dr. Subramanian from Dr. Geeta Thakur. She has asked, like, what is the role of monoclonal antibodies in COVID management and what are the risk factors for the same?
So apparently we had a good discussion on this by Dr. Hiren Mehta. In fact, they have run a lot of trials, and they had all these cocktail antibodies, monoclonal antibodies. So this monoclonal antibody is a vast thing, right from tocilizumab, baricitinib, all these are monoclonal antibodies. And now we have these cocktail antibodies where 2 antibodies are combined and given COVID. So all have different indications. Whatever said and done, I would, this monoclonal antibodies, you have to be really selective. It is like how like we have all these RA-induced ILDs whom we think of giving rituximab. So all these days, whenever you send them to rheumatologists, they won't even think of stopping even doing a PET CT to ensure that there is no infection in this patient and no secondary infection and no kind of TB or anything. And then only they would administer rituximab, because they don't want the patient to have any kind of severe secondary infection. It's going to really hit your immune system and suppress it. So there are the risk factors is you need to have zero secondary infection, except other than COVID, you shouldn't have any other infection to give tocilizumab, baricitinib. And regarding cocktail antibodies, given only in stable patients not requiring antibodies. Bit costly drug I have given in one patient. And I think there are a lot of trials they are recommending in many patients with high risk factors. So we should consider only when we start giving these drugs, then the cost would also come down. The government will also try to pressurize these MNCs to get the costs down, like how they did with remdesivir and other drugs.
Okay.
And another question is to Dr. Poonam. After how many days, Dr. Yogesh Kataria has asked, after how many days should a patient take a Covishield after he has taken 2 doses of Covaxin?
So I don't think there are any fixed guidelines on that. This cocktail vaccination is again under review, and maybe like when we get the guidelines, we will get back to you for this.
We can even take it. The system will not show up.
Yeah,
Yeah.
true.
Off-label. So one question to Dr. Ashit Hegde from Dr. Suhas Monalkar. Sir, any data on HIV reactive patient on ART being COVID positive? If no, then are ARTs effective against COVID as it is mRNA virus?
Oh, lopinavir ritonavir was initially prescribed for COVID, before we had remdesivir. It was shown to be not useful and a lot of side effects, especially those, of course, people getting azithromycin, chloroquine, QT prolongation, etc., more diarrhea. So I don't think lopinavir ritonavir, except the patient already is on that drug for HIV, there is no treatment for COVID. But for HIV with COVID, we will probably, they come in the high risk category, so they are admitted. We would probably give them remdesivir. But otherwise, the standard anti-HIV drugs would not work for COVID. I mean, they're not recommended for the management of COVID. At least what was used initially did not show to be effective.
Okay. So, Dr. Santosh Kadam. So they were saying that there was a lot of mortality in the second wave amongst young adults. So was it the case even in Thane and Mumbai, or what was our Mumbai data showing? Was it so, or was it?
Yes. Like in the first wave, like we were getting a lot of time. Somebody getting a COVID infection, we used to monitor at home also, and then we were encouraging home isolation also. This time we encouraged home isolation only because we were running short of beds. But then many adults presented in a very short duration of course, like fever for 2-3 days, and again there was lung involvement, and they were coming with hypoxia. Many were not tested. Many patients were coming with hypoxia, and the second wave definitely, I think it was more virulent, probably Delta, and there is a lot of mortality in young adults also as compared to the first wave.
Okay.
Okay, so one question to Dr. Bhumkar from Dr. Chandrakant Wagh. He has asked that after completing dose of amphotericin B, for how many days you should give posaconazole?
Standard guidelines is 3 months. But again, like we are seeing a different Mucor in an immunocompetent patient now. So things are now getting customized. A rough guideline is to monitor a sequential CRP monitoring. And if the CRP tends to fall very rapidly and comes to under 10, this is the time when we are saying we can wait and watch, because like I told you, we have modified our surgical technique, putting an endoscope and doing a surveillance of the entire walls of the sinuses is now become very easy in the post-op period. So there are 2 or 3 factors. The standard answer is 3 months, but we are also having people in 2 months trying to stop the posaconazole. So depends on the blood parameters and the clinical condition.
So next question is by Dr. Rakesh Sarosh to Dr. Poonam. Which test can be done to check protection level after vaccination?
Yeah, so I think it has been repeatedly mentioned that please don't check your antibody levels, don't do any blood test post-vaccination. It is assumed, and it is definitely gives you a fair amount of protection, which has been shown in studies. But all the more, if you really want to do it for some specific purpose, then you can always do a anti-SARS-CoV-2 spike glycoprotein test. That will definitely help. You to see your post-vaccination antibody levels.
Okay, the next question is to Dr. Hegde from Dr. Meenal. Use of ivermectin in mildly symptomatic patients.
Again, controversial, but at the moment, not enough evidence to say ivermectin works. In fact, it's been removed from most of the guidelines for treatment of. Initially, it was there, but now even the WHO has taken it off, and even our own country has taken it off the guidelines. I must tell you about our own hospital. We have got more than 1,500 staffers who have been, been mildly. Most of course are young, mildly symptomatic. We give them almost nothing except paracetamol. Nobody got anything. No chloroquine, no azithromycin, no ivermectin, nothing. And we have only one patient who has died, and barely less than 10 or 15 in the ICU. So I think by and large, especially mild disease, get better on their own. And you give them something and that drug gets the credit. Most of the time, it's the body doing its job. I think all these drugs, as Dr. Kishore Subramanian talked about in his list, the list of medicines, all of them are practically useless. So probably the body is the hero. I think by and large, nothing is required actually.
I may add, I think I was also asked about mucor mycosis. I think respecting the microbiome, the natural microbiome and the equilibrium of the body, and just trying to do something with the hope. And this is where I think even the drug resistance, forget about ICUs. I mean, we're taking 5 antibiotics for a viral infection. I mean, where did we start? What sort of medicine are we using? I mean, every antibiotic, antiparasite, all kinds of things, some evidence that it may perhaps work. But I think these are all the predisposing factors to mucor-like things showing up. So I think understanding a body's natural equilibrium and understanding that the microbiome, and you try to shift one square, the other square is going to get automatically shifted. So I think this holistic approach is we are obliged to respect this equilibrium of the microbiome and not play with it.
Okay, so one question to Dr. Ashit Hegde from Dr. Amay Gursale. So he's asked that what is the use of piroxicam in mild COVID, since it was postulated that there is some role in cytokine storm prevention.
See, I mean, there are some patients, especially the second wave, who continue to have fever beyond 7 to 8 days, and they become a little, anxious. Quite often, the tendency for them is for people to prescribe steroids in those situations. So, in those situations, rather than prescribing steroids, sometimes I do, prescribe an NSAID, not necessarily piroxicam, any NSAID, even Combiflam or whatever. And I'd watch them. Of course, I'd watch this patient a little more closely. I'd probably watch the CRP, watch the saturation, but I would not jump to steroids because it's quite tempting when 6 days have passed, 7 days have passed. You're worried about them going into a cytokine storm, and so I understand it needs to be watched closely. But I would probably in those situations first try, especially the younger group, try an NSAID rather than jumping to a steroid, because as the studies have shown, unless they're clearly hypoxic requiring oxygen, steroids may actually be harmful. But yeah, there is probably that role in patients who continue to be febrile after 5 or 6 days. They're not responding only to paracetamol. I think first we should try paracetamol in reasonable dose, up to 3.5 grams a day. If that doesn't work, I might try an NSAID for symptomatic relief. But I'd watch them a little closely.
Now, with your permission, I want to say that this is regarding the earlier question. I think the very first question we asked in this COVID pandemic was the wrong question. We asked the question, how should we treat COVID? Our question should have been, how does a COVID patient heal himself or herself? Because in how should we treat, we started finding or looking for that red, white, yellow, green pill, which we should give. I think that's where the compulsion came, rather than to step back and watch how the patient actually heals. That is what Ashit is saying, that just with paracetamol, hundreds of his colleagues in Hinduja and others have actually healed themselves and cured. This is, I think, something which we need to step back and look at the entire scenario rather than feeling the urge to add one more drug, and one more drug.
True, perfectly right, sir.
So I think by and large, I think we have finished most of the questions, and it was a beautiful panel discussion. Thank you all panelists. Over to you. Yes, sir. Yes, sir.
Conducted by a wonderful couple.
Thank you.
Thank you.
Thank you. Thank you, sir.
Thank you, sir. Thank you for joining in, Dr. Ashit Hegde, Dr. Ashish Bhunkar, sir, and Dr. Santosh Kadam, sir. Please, very
I must just tell you, normally I would not. From 9 o'clock, I've been listening attentively. Never happened.
It's a big privilege, sir.
No, I'm happy. I'm happy. I've never done this for 4 hours on a Sunday. I've never dreamed of it. It was so engaging.
It's an honor for us.
No, I'm very happy.
Thank you, Poonam and Natarajan. We have been doing it for the last 7 years, but this one was the topper.
Yeah, thank you, sir.
Thank you,
Dr. Ramchandani, sir.
Thank you. Over to you, Dr. Tina.
Thank you, sir.
Once a great man whispered, feeling thankfulness and not expressing it is like wrapping a present and not giving it. So, we would like to express our gratitude to all the esteemed delegates for their presence and contribution to make this webinar a grand success. Also, a big thumbs up to all our honorable speakers for making excellent presentation and making this webinar interesting and meaningful. We would like to thank the technical team, Mr. Jeetu Thakkar from Primo Digital Solution, who has been there with us since last many years, and his team, Khalil Bhai and Aditya Bhai. We thank you all once again for being with us today. It has been a great pleasure interacting with all of you. Thank you so much. Take care.
Thank you all. We stop the webinar. Thank you. And all your certificates and all would be directly sent to MMC. We have all your registration numbers on the Google Forms, so shouldn't be a problem. We'll be talking to the IMA clerks and then get this thing done. Okay, don't worry about it. Thank you so much, all of you all. Bye.